bills today. In the morning will be, yes, 3 bills in order, 85, 74, and 118, in which they were published. And then this afternoon, we'll be hearing from some statutory agencies for which we have some responsibility. So everything now is viewable on YouTube and has been audible since you first joined the meeting. We're getting better at this for those of you who are guests and observers, but we still have lots to learn. We're not learning quite as fast as we were because we've made a lot of mistakes already. But so please be patient with us if you would. Everybody's been good during the hearings, mostly about keeping themselves on mute if you're on the committee and visible as much as possible. So I appreciate that. I'm turning off my phone because last year it cost me $15. Just a reminder that we can't put anything of any substance in the chat. That's just for facilitating running of the meeting. So if you're here to testify, we ask that you identify yourself underneath your picture so that we know who we're talking to, and that when you're done with testimony that you go to the YouTube channel to watch the rest of the hearing so we can make room for additional people. Written testimony can be submitted up until the time we vote on a bill, so you still have time if you haven't turned that in. And we'll start with 5 minutes or so for the introductions, longer if necessary for complicated issues, but then we'll go to a 3-minute timer, which represents about 1.5 pages of double-spaced testimony, and ask that you stick as close to that as possible. So let's go around and introduce ourselves. I'll do it based on what I see here, starting with Representative Zager.
Good morning, everyone. My name is Sam Zager, honored to represent District 41 in Portland.
We have a couple of people who are tied up elsewhere in other committees. That gets us to Senator Baldacci.
Good morning, everyone. I am Joe Baldacci. I'm a member of the State Senate. I represent the city of Bangor and the town of Herman. Thank you.
Representative Perry is here from the Far East.
Good morning. I'm Representative Ann Perry. I represent District 140. It's early in the morning. And I represent the communities of Indian Township, Baileyville, Bering, Callish, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Griffin.
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Caduscag.
And Representative Craven is here.
Thank you, Mr. Chair. Good morning. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Senator Moore.
Good morning. I'm Marianne Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
And Representative Javner.
Good morning. I'm Representative Kathy Javner. I represent House District 141, which is located in Penobscot and Washington counties.
Representative Meyer.
Good morning and welcome to all those joining us around our virtual horseshoe today. I'm Representative Michelle Meyer, serving Southern Maine's District 2, which is Elliott and parts of South Berwick and Kittery.
And I'm Ned Claxton, and I'm honored to serve the Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We are joined by Anna Broom. If you'd introduce yourself.
Hi, I'm Anna Broom. I'm the legislative analyst for this committee. I work in the Nonpartisan Office of Policy and Legal Analysis. And I just also want to let you know that you have preliminary fiscal impact statements on the web for LDs 85 and 118. And there's also current law for LD 118, although it really just shows where it fits. So you could probably skip looking at that for the time being.
Thank you for that. And we also have Carrie Withy with us.
Good morning. My name is Carrie Withy, and I'm the clerk for the Health and Human Services Committee.
Thank you to the latter two for being here. They're the glue that holds the committee together. So thank you. So let's start with LD 85. And as I understand it, one of our very own members will have to step outside the horseshoe, the virtual horseshoe, and present this testimony. So welcome, Representative Craven. You're on mute. There we go.
Thank you very much. Good morning, Senator Claxton, Representative Myers, and fellow members of the Health and Human Services Committee. My name is Margaret Craven, and I represent House District 59, which is part of Lewiston. I'm pleased to be in front of you today, or with you today, to introduce LD 85, an act concerning main care coverage for donor breast milk. This bill requires that the Department of Health and Human Services to provide reimbursement under the main care program for pasteurized donor breast milk if a physician, physician's assistant, or advanced practice registered nurse signs the breast milk, that breast milk is medically necessary, similar to writing a prescription for a needed medication. This bill would also require that the infant's mother be medically or physically unable to produce enough breast milk for the infant, or the infant is physically or medically unable to receive their mother's breast milk, are unable to breastfeed. This additional requirement ensures that the main care program would reimburse for donor breast milk for those with a proven need. Some Maine hospitals provide donor milk for inpatient premature babies or full-term babies whose mothers are struggling to establish lactation. It is known that breast milk guards against a host of serious illnesses, and for premature babies, this can be crucial for their health and well-being. Currently, donor breast milk costs roughly $4, it's really $4.75 per ounce, which is a price that puts it out of reach for many Maine care families. This bill is about equitable access to human milk for Maine babies by ensuring more families have access to donor milk. Maine will see improved long and short-term health outcomes for babies and overall public health for the state. I'm proud that Maine has, actually, they have 5 different drop-off areas for donors. One is in Portland, one is in Damariscotta, one is in Rockport, Belfast, and Lewiston. So when Lewiston was launching their collection site, that's when I became aware of this benefit. For those members who are returning this year, I do want to mention that when this bill was before you during the 129th legislature, the committee unanimously voted ought to pass and as amended. But the legislature, of course, reconvened, wasn't able, to continue because of the pandemic. I would be in support of bringing the language, the language from the committee's amendment and adding it to the bill before you. The amendment changed the criteria in which the infant received main care benefits may receive donor milk, breast milk, to be consistent with the current coverage for donor breast milk under the federal TRICARE program. Thank you for your time and consideration, and we'd be happy to answer any questions.
Thank you for your testimony. Are there any questions for Representative Craven? I don't see any, thank you. So you may resume your position behind the virtual horseshoe. So we have several folks who'd like to testify related to this. Some for and some neither for nor against. And the first one is Kathy Kakini. If you'd care to unmute and join us, we'd be glad to have you.
Hi, is that Kara Kaikini or Kathy Kilrain Del Rio?
No, it's Carrie Kakini, and I couldn't know how to pronounce it. So welcome.
Okay. Thank you. Hello, Senator Claxton, Representative Meyer, and members of the committee. My name is Kara Kaikini and I live in Freeport. I'm here today to speak in support of LD 85 as a board certified lactation consultant and as the board president of the Maine State Breastfeeding Coalition. The Breastfeeding Coalition supports this bill because it would substantially increase the number of babies who exclusively receive human milk. We know that babies who are fed breast milk are healthier. Babies who are not fed breast milk are at a greater risk of necrotizing enterocolitis or NEC, respiratory tract and ear infections, SIDS or sudden infant death syndrome, and are at higher risk of developing diabetes, obesity, and allergic diseases. The more exclusive and the longer in duration babies receive breast milk, the lower their risk and severity of these outcomes. So World and national health organizations all recommend infants be exclusively breastfed for 6 months after birth, with continued breastfeeding for at least 12 months. The American Academy of Pediatrics and the World Health Organization state that if mother's own milk is not available, pasteurized donor milk should be used. Action 12 of the Surgeon General's Call to Action to Support Breastfeeding calls to identify and address obstacles to greater availability of safe banked donor milk, including examining models of payment like insurance coverage. Making donor milk available to all infants who receive Maine care would improve newborn health and save money in the state of Maine by reducing risks of illnesses and readmissions. One study found that if 90% of infants could exclusively receive breast milk for the recommended 6 months, our economy could save $13 billion per year in direct and indirect pediatric health costs and prevent in excess of 911 deaths. Formula use in the early days is associated with decreased breastfeeding duration and a negative impact on an infant intestinal microbiota. We are glad we have formula. Those of us who support breastfeeding aren't against using formula. We simply want the best evidence-based options to be available to all babies. Formula is not the next best or recommended option to mother's own milk. Donor milk is. And right now, donor milk is not equitable or accessible to all families due to its necessary cost. Families need all of you in this room to support the financial health of new parents and physical health of their babies. So I urge you to support LD 85. Thank you for your time and consideration.
And thank you for your testimony. Are there questions from anyone on the committee? I don't see any, so thank you for being here. Next, we'll go to Kathy Kilrain Del Rio and hear from her. Welcome.
Thank you all. Good morning, Senator Claxton, Representative Meyer, and members of the Committee on Health and Human Services. My name is Kathy Kilrain Del Rio. I'm with Maine Equal Justice, a nonprofit legal aid provider working to increase economic security, opportunity, and equity for people in Maine. We support LD 85, and today, unlike my usual appearance before you, I'm testifying on behalf of my colleague, Brandy Collins, who some of you heard last year. She couldn't be here today, but wanted to share again her personal experience as a mom whose child was born 8 weeks prematurely. So the rest of my testimony is actually her words. On the morning of April 20th, 2018, I received the news that no mother wants to hear. I was told that my unborn infant daughter was in distress and that I would need to be prepped for an emergency C-section. I was only 31 weeks pregnant. On April 20th at 9:50 a.m., my daughter, Harper Gray Collins, was born, weighing in at only 2 pounds, 8 ounces. Harper was immediately taken to the NICU after she was born and placed on a breathing machine. I was told that Harper would most likely be in the hospital until her due date, which was June 17th. I don't believe that any mother is prepared for the long, stressful road ahead of having an infant in the NICU. Seeing your child hook up to so many machines and wires was not something I was prepared for. Harper was placed on a feeding tube because due to her prematurity, she did not yet have the muscle coordination to breastfeed. During this time, I was not able to hold Harper and breastfeed her, so I spent most of my time sitting next to her incubator pumping breast milk to keep my supply for when she was strong enough to try breastfeeding. Before having Harper, I had read all the benefits of breast milk and had always planned to breastfeed, so it was very upsetting for me that this was not a possibility. Due to my daughter being so small, she only required small amounts of breast milk, so during her hospital stay, I was able to provide that for her along with supplementation of donor milk that was provided. Unfortunately, when I came home, I was not able to keep up with the demands of exclusively pumping, as she required more calories and quantity in order to continue gaining weight. My husband and I were both working and had a toddler. My supply began to dwindle, and I knew that I would not be able to provide her with the breast milk for much longer. I researched buying donor milk and found that it was very expensive and knew I couldn't afford this as a long-term solution. So I turned to an online community of mothers willing to donate their milk. I was very fortunate to find a mother whom I trusted and connected with, who was able to provide me with enough breast milk to supply Harper until she was over a year old. Although I was able to find a wonderful donor, there are many safety risks associated with mother-to-mother milk sharing. For parents coping with the birth of a premature baby, there are many factors that make it difficult or impossible to produce adequate breast milk to meet their child's nutritional needs. Their body may not have been ready to produce milk. They are coping with a great deal of stress and exhaustion while their child is in the NICU, and often they are balancing the care of their tiny baby with work, caring for other children, and even traveling long distances to the hospital. For these parents, donated breast milk is an important option. However, for parents with low income, that option is often financially out of reach. While the challenges faced by parents of full-term babies are different from those I've described, donated breast milk can still make a big difference in those babies' health as well. And those benefits shouldn't be denied to low-income families who are already struggling to make ends meet. For all these reasons, I urge you to vote ought to pass on LD 85. For some families, donor breast milk can have a big impact in a child's health, and those families with main care coverage need to be able to access this important resource. I'm happy to answer any questions you have. Thank you.
Thank you for that testimony. And does anybody have any questions? I don't see anything, Ms. Del Rio, so thank you for being here.
Thank you.
And Molly Bogart has joined us.
Good morning, Senator Claxton, Representative Meyer, Representative Craven, sponsor, and members of the committee. Thanks for allowing me the opportunity to testify this morning. My name is Molly Bogart. I'm the Director of Government Relations for the Department of Health and Human Services. And today I'm largely bringing to your attention a letter that you've received from Director Probert at the Office of Main Care Services. We want to provide this just as informational for you. We certainly recognize that breast milk can be an important component of raising a healthy child, and wanted you to know that the Ohio Medicaid program covers donor breast milk at $4.75 per ounce as durable medical equipment once a child is released from the hospital and is eligible. No payment in that situation is made for the milk itself, but it is for the processing and shipping. And as Representative Craven reminded the committee last year, you amended this to include the TRICARE eligibility criteria, which we would encourage you to do. Again, just provide some clarity around eligibility for the service. So as with all new services, this would have a fiscal impact, although I believe it'll be relatively small. And we're happy to answer any other questions that you have about the Medicaid aspect of this.
Thank you for being here, Ms. Bogart. Thank you for that testimony. Are there any questions for Molly? Yes, Representative Craven.
Thank you, Mr. Chair. I just wanted to thank Molly for being kind.
My pleasure. You just made my day. Good to work with you.
That's any other kudos for Molly or any other questions for her? Okay, so next we're going to hear from Naomi Bar-Yam. And I apologize for the pronunciation.
No, that was actually fine. Thank you. Good morning. And to Representative Claxton, Representative Meyer, members of the committee, and Representative Craven, who introduced the bill. Thank you for this opportunity to express my support for LD 85. My name is Naomi Bar-Yam. I am the founding director of Mother's Milk Bank Northeast. Similar to 10 other states and Washington, D.C. that offer Medicaid coverage of donor milk, LD 85 demonstrates the commitment of the Maine legislature to ensuring equitable access to donor milk for premature and fragile babies, both in hospital and at home. This, as we have heard, will improve health outcomes and save money for the state of Maine. According to the National Center for Health Statistics and March of Dimes Peristats, about 8.6% of the 12,000 babies born in Maine in 2018 were premature. That's just over 1,000 babies. before 37 weeks gestation. Of those, about 100 were born very preterm, before 32 weeks of what should be a 40-week pregnancy. These tiny babies are at the highest risk to contract necrotizing enterocolitis, NEC, a very serious and very costly infection of the gut. Multiple research studies over decades tell us that the only consistent independent predictors for NEC are prematurity and formula feeding. LD85 will cover donor milk for babies with medical need as prescribed by their healthcare providers. Donor milk supports mothers to breastfeed. Most often, outpatient mother-baby dyads use donor milk for a week or two to support the mothers and to supplement their milk until their supply fully comes in. Main care coverage for medically indicated donor milk use will pay for itself several times over in a number of respects. First, direct long and short-term health improvements for premature babies. There will be fewer cases and reduced severity of NEC, sepsis, and other diseases that are both, again, serious and costly. Second, cost savings and improved public health for the state of Maine. More mothers will be able to breastfeed their babies for longer, resulting in multiple short and long-term health and cost-saving effects. And finally, equitable distribution of resources. Prematurity and breastfeeding are not distributed equally across the population. Families on main care are more likely to have premature and sick babies and less likely to breastfeed. LD85 will help assure equitable access to the support and donor milk Maine's babies need to both survive and thrive. Mother's Milk Bank Northeast is eager to work closely with the Health and Human Services Committee on refining the details of this bill, including the amendment that Representative Craven mentioned, and with the Health and Human Services Department on its implementation. Please do not hesitate to call upon us. Draw upon the expertise of our esteemed physicians and researchers and other practitioners on our medical and research advisory boards in services of the citizens of Maine. Thank you.
And thank you for your testimony, Ms. Baryoung. Are there any questions for her? I have one. I noticed that you're listed as neither for nor against. Is that because of the stance of the entity or that you represent?
No, that was a mistake. I thought I clicked for.
Okay. All right.
Yeah, I either didn't go through straight or I made a mistake. I apologize.
No, it sounded like a good, sounded like an endorsement, and I just wanted to make sure that was
yes,
recognized as such. So
definitely.
And we may take advantage of your expertise definitely when we get to the work session. And there's some consideration for whether we might be able to do that later on this morning. I'd like to have several other members of the committee here first. So thank you very much for your testimony.
Great, thank you.
Next, we're joined by Robin Snyder-Drummond. Welcome. Would you?
Hello, can you see me?
We can't see you yet, but we can hear you.
Okay, maybe now.
There we go.
Okay. Good morning to all the members of the committee. Thank you for your time. My name is Robin Snyder-Drummond. I'm a board certified lactation consultant. I live in Ellsworth, Maine, and I am in full support of LD 85 Maine care coverage for donor human milk. And there's one main reason why this is important. All of us are acutely aware of our immune system in this pandemic year. Fundamental to our health is an impermeable gut membrane. It protects us from bacteria and toxins, antigens getting into our system. So hopefully, as adults, we have that. Newborn babies do not. A newborn baby, preterm or full term, has an immature gut membrane, which means it's kind of porous, which means bacteria, toxins can get through the membrane into the bloodstream and cause inflammation and infection. So every newborn is vulnerable. However, nature has planned that the first thing that goes into a baby's gut is human breast milk. So the breast milk coats the lining of the gut membrane and it provides protection. Number one, It's lower in pH, lower than formula, so bacteria doesn't thrive as well. Number two, it's a live food with active macrophages that surround and chew up and spew out the toxins from the baby's system. And number three, it has growth factors that actually help in the development of the gut membrane. So by the time a baby is 6 months old, that gut membrane is impermeable and nice and healthy. By the time a baby is 6 months old, they're sitting up, eating food, putting things in their mouth, and their immune system can better handle it. So you can give a baby fats, proteins, carbohydrates, etc., but they have a profound need for the finely tuned amounts of essential fatty acids, growth factors, and especially the anti-infective properties of human breast milk. So medical science has made amazing advances in neonatal care, and still there's no substitute for human breast milk. Babies have a profound need to absorb this most excellent nutrition from the very start. That is the main reason I always support donor human milk for every baby that needs it. Thank you for considering the deeper implications of this policy. Thank you.
Thank you for all that information, Ms. Snyder-Drummond. Appreciate it. Are there any questions for her? I don't see any.
Okay.
So thank you for being here.
Okay,
So
thank you for your time.
I think what we'll do is take 5 minutes to make sure there isn't somebody else who'd like to testify on this bill, and to give our clerk a chance to get ready for the next bill. So can we return here at 9:35? Carrie, did that give you enough time to do what you needed to do? Okay. So we'll resume this hearing from Health and Human Services. There apparently is nobody else who'd like to testify related to LD 85. So that will conclude the public hearing section on LD 85. And we'll move now to consideration of LD 74. We're joined by Representative McCray, whose internet is sketchy this morning, but we're glad to have you here, sir, to introduce this bill.
Great, thank you very much. It's good to see so many people that return from the 129th, and good to see people that I don't know yet. So I look forward to meeting you in person, those of you that I have not. Good morning, Senator Claxton, Representative Meyer, and esteemed members of the Joint Committee on Health and Human Services. I'm Representative Dave McCray, representing House District 148 up in central Aroostook County. And I might add, we're on a heat wave this morning. It was 20 below here yesterday morning. It's only 16 below today. Okay, I say that just to make all the rest of you feel good. I reside in the town of Fort Fairfield and have done so proudly all of my life to date. In case this bill sounds familiar to some of you, that would be due to the fact that I presented it in the 129th legislature. It was passed out of this committee, as ought to pass, of course, and in the 129th legislature was passed by the House and eventually died in possession of the Senate at the conclusion of the 129th legislature due to the fact that we did not reconvene. I became aware after I resubmitted this bill that the title had been amended by the committee as follows, and it was resolved to ensure appropriate personal needs allowances for persons residing in nursing facilities. I have no problem if that is amended to that new title. I also believe that there may have been some subsequent amendments before it went on to the House, and I have no problem if we do that, perhaps at the work session, depending on the desire of the committee. I originally submitted this bill on behalf of a constituent in Easton, Maine, whose mother was in a long-term care facility. Sadly, she has passed away in the meantime. The personal needs referred to in this bill is the amount of money that a person in a nursing home or other long-term care facility may keep from their monthly income, which would consist of Social Security benefits, pensions, retirements, etc. Currently, that monthly amount is set at $40 per month. The facility keeps everything else, and it has not changed in approximately 25 to 30 years. I do realize that these facilities have expanded the number of items that they provide and services that they provide. However, such items as really personal care items, hearing aid batteries, hair care, toiletries, razors, etc., are not provided by the facilities and certainly cannot be covered by the simple $40 per month. In some cases, that's not a big problem because the family can certainly do that. But in most cases, it's a real burden. This bill asks to move the personal needs amount from that $40 a month to $70 per month. I wish to thank this committee for allowing me to present this much needed and basic care bill. I would be happy to entertain any questions you may have, and I certainly will make myself available for the work session. Thank you very much.
And thank you, Representative McCray. Glad you could be here. Senator Baldacci has a question.
Good morning, Representative McCray.
Good morning, Senator.
I wanted to, first of all, thank you for introducing this bill. I think that all of us are familiar, who are familiar with families having someone in a long-term care facility, understand the importance of this issue. The question I wanted to ask is whether it would be appropriate to add a clause in to have the amounts annually adjusted according to inflation, so that we're not waiting 25 years before we make further adjustments on that. Would that be something that would be okay with, as the author of this? Is that a friendly kind of amendment, or?
Well, I appreciate that, and I absolutely would be in favor of that. I think that these things get passed with the very best of intentions and maybe the way it should be, and then forgotten for 25 years. So regardless of how far we can push this now in a tight time, I'd be in favor of any kind of amendment that would help it keep pace with time in the future. So thank you very much for that suggestion, Senator. It's good to meet you, by the way.
Good to talk to you as well. Good, and I look forward to being in Fort Fairfield sometime soon.
I hope
After
you do.
Yeah.
After it warms up. Are there any other questions of the committee? I don't see anything, Representative McCray, so thank you very much.
You're very welcome. Have a good day.
We have a couple other folks here who would like to testify in support of this amendment, of this bill. So let's start with Brenda Gallant, if you would join us.
Yes. Oh, gosh.
Welcome.
Thank you. Good morning, Senator Claxton, Representative Meyer, committee members. Wait a minute.
We can see you for a little bit.
I know. It keeps going off. I apologize.
Okay. All right.
I don't know why. So my name is Brenda Gallant. As you know, I'm the long-term care ombudsman. And for those who are listening, our program, as you know, provides advocacy for long-term care consumers across the continuum of long-term services and supports. Representative McCray is right. The personal needs allowances have not, both in residential care and in nursing homes, have not been increased since the 70s. I'd like to point out that, which I did include in my testimony, the personal needs allowance for residents in nursing homes in Maine is the lowest in New England. You can see the other states provide higher personal needs allowance. And this is important because Maine Care provides funding for simple things like toothpaste, shampoo, incontinence products, that kind of thing. However, the personal needs is really the only amount of money that residents are allowed to keep. And just think about it this way. So if they want the newspaper, if they want to get a haircut, if they want a telephone, and particularly in these times when families have been restricted in terms of visitation, the telephone becomes very important. So this is really just a little bit of money set aside for that resident to be able to spend. So we think it's really important. So we support this legislation wholeheartedly. We think it's time for a change. And if you have any questions, I'd be glad to answer them.
Thank you for your testimony. Yes, Representative Craven has a question.
Thank you, Mr. Chair. I probably should have asked this of Representative McCray, but do you know if this covers people who are living in group homes and have IDD or other PNMI facilities?
The legislation as it's written, and it covers people in nursing homes and in residential care facilities. So I can find out for the work session, but I'm assuming at least that's the PNMI's Appendix C. And I'm not sure about the others, but we could get an answer for the work session.
Thank you. Are there other questions? Yes, Senator Baldacci.
Thank you. I think for the work session too, I would ask if we could just find out when these amounts were first or last established or last adjusted, and when that, so we know when that was and the relative inflation rates since that point in time. I mean, just so I have put it in some context. But as I indicated, I totally agree with this change. I just want to make sure that we don't have to just leave this unadjusted for another 20 years. Thank you.
Thank you.
Thank you for that question. Are there any others? I don't see any. Thank you. Thank you for being here, Ms. Gallant. Next, we'll hear from Nadine Grosso. Welcome. Nope, you're still muted. I'm sorry.
There we go. I don't know what that was all about. Thank you. Good morning. My name is Nadine Grosso, and I'm the Vice President and Director of Communications with the Maine Healthcare Association. Senator Claxton, Representative Meyer, and members of the committee, on behalf of the Healthcare Association, it is our pleasure to support this bill today. I don't want to repeat so far what both witnesses have said.
But, by way of background, and it's funny, we all have different years when we think this was last adjusted, but I think it's fair to say that it's long overdue. And I think that you've already heard about what kinds of things that this pays for. So I don't need to sort of repeat that. But from a facility, strictly from a long-term care facility perspective, I did want to let you know that facilities are diligent in their oversight of these funds. There's a process in place contacting families and responsible parties before the funds are actually depleted. And basically members have said in the past that if families and responsible parties are unable or unwilling to provide the resources, the need is still met, whether it's donations, staff member contributions, or other facility funds. I mean, I think many, facilities go to great lengths to make sure that the needs still are being met. I think that's part of the reason why this hasn't gone any further than the policy committee over the years. But we believe that it is, as I said, again, it is long overdue, particularly in the time of COVID-19, where families could bring things in before. I mean, obviously that was a real challenge this year. And so for a long time, you couldn't even accept packages at the facility. So again, staff and facility have really stepped up to make sure that whatever residents have needed, particularly during this time, make sure that they get what they need. So with that, I don't really have anything new. You have our written testimony. I'd be happy to try to answer any questions you might have, but we are pleased to support this bill and would really like to see it get over the finish line, and really like Senator Baldacci's suggestion on some sort of cost of living adjustment if this were to pass, so that we weren't dealing with this kind of year after year. Thank you.
Or every 25 years.
Or 30, depending
Or
on
30,
whose testimony you want to
Right.
believe. Right.
Thank you for being here for the testimony. Are there any questions for Ms. Grosso? I don't see any, so thank you. Carrie, do you need some time to check and see if there's anybody else who'd like to testify?
Yes, I'll take just a couple minutes, I think.
All right, so that'll get us to 9:50. See you back here then.
Representative Madigan, we're on a short 5-minute break.
Oh, okay. What's the reason for the break?
To allow Carrie to check to see if there's any more that want to testify on LD 74.
Okay, thank you.
You're welcome.
So I understand that there are no additional folks who want to testify on LD 74. So that will conclude the public hearing on LD 74, and we'll move on from there. Before I introduce the next bill, which is LD 118, an act to address main shortage of behavioral health services for minors, it'll be presented by Representative McCray. I'm going to step away as the chair and turn it over to Representative Meyer, because I need to testify in about 9 minutes someplace else, but I'll be back. So welcome, Representative McCray, and you're going to introduce your bill.
Thank you. Hey, everybody. Nice to be back in front of HHS. It scared me a little bit when I heard Representative McCray's bill was next. Sounds a lot like McCray. Senator Claxton, Representative Meyer, esteemed members of the Health and Human Services Committee, I'm Jay McCray, representing House District 51, Harpswell, West Bath, and Northeast Brunswick. And I'm here today to present LD 118, an act to address Maine's shortage of behavioral health services for minors. The purpose of this proposal is to effectively address the ongoing crisis of children and adolescents enduring extended stays in hospital emergency rooms, or EDs. Of course, it's not just the young people who suffer, it's their families, their communities, and our healthcare system. I'm talking here about cases where the young person is brought to the ED in crisis, often demonstrating aggressive, out of control behavior. Even when medically cleared for discharge, however, they have often to remain for days, even weeks, and even months in emergency departments while waiting to get the care they really need. Services to address the issue that brought about the crisis in the first place. In other words, their behavioral health needs. Having worked as a social worker and clinical counselor for my career, including work as a crisis unit clinician, I can attest to the shortage of behavioral health services and facilities that has only gotten more severe over the years. The shortage is harmful, counterproductive, and extremely expensive. Emergency departments are intended for exactly what the name says, emergencies, not ongoing behavioral health care. The rooms are frequently tiny, windowless, lacking in privacy, with security guards on duty, where the child remains long past the time when hospital level care is needed. This just exacerbates the problem that brought the young person to the ED in the first place. This committee worked very hard on this bill in the 129th, as those of you who were here then may remember. The bill before you today includes much of the amendment the committee passed unanimously at that time, and which was not opposed by the Department of Health and Human Services. Still included in the bill that I put before you is the provision that the department will post aggregated, non-identifiable information on the numbers of children stuck in EDs for over 24 hours and post it on the public dashboard. Annual report backs to the committee are also still included. The new portion is the proposal to have a work group that will dig into the problem and develop a specific plan. As proposed here, the work group would be established through the Children's Cabinet and made up of a broad representation of those with direct experience and insight into this crisis. The tasks of the work group are also identified in the bill. They include data collection, not just numbers of children who are stuck, but diagnoses, demographics, behavioral health needs. This data would be used to identify gaps in our behavioral health system, such as psychiatric hospital beds, partial hospitalization programs, residential treatment beds, home-based and crisis services, and to identify the barriers to service delivery, such as those specific to rural parts of the state, workforce needs, communication among providers, and others. And finally, development of a specific and detailed plan. Also included is a report back to the committee by February 1st, 2022. I thank the department for giving me the heads up that they're not as thrilled as I am with my idea about the Children's Cabinet. I had been working to figure out what was the best course of action before proposing the Children's Cabinet. So I would suggest that the committee consider the alternative of a legislatively established work group, as we have done to address other complicated issues, the opioid crisis, issues around older adults, children's mental health, and other issues. Regardless, I can't stress enough how important it is that we take action. We know there's a problem. We know it's causing harm both emotionally and physically. We have the opportunity now to zero in to do the work, to determine specifically what course we need to take to better meet the behavioral health needs of our young people. I respectfully ask the committee to support actions that will help resolve the crisis. I want to thank you for your attention and especially to thank your analyst, Anna Broom, for her work on this bill last session and this session. And I'll do my best to answer your questions.
Thank you, Representative McCreight. Questions from the committee? Yes, Representative Madigan.
Thank you. Thank you, Representative McCreight. I'm wondering if you could speak a little more about your suggestion about a legislatively designated or created work group around this and what that would look like and what sort of power enforcement kind of it would have and who would comprise something like that.
Sure.
This idea intrigues me.
Oh, sorry, I didn't hear the last part.
This intrigues me. I mean, because we've been trying to deal with it for a while, and I think there's a lot of people genuinely care about this.
Yeah, I agree. Well, the idea of the Children's Cabinet was appealing because already on the Children's Cabinet are a lot of the people that we need to address the issue. It's not unusual that a child who comes in crisis with aggressive behavior might end up at Long Creek, for example. So Children's Cabinet has corrections people on it, public safety, as well as healthcare, traditional healthcare. And I had suggested it. We need to make sure that we have behavioral health specialists, not just mental health, not just substance use disorder, but disabilities, intellectual disabilities, developmental disabilities, so that we have the spectrum of the kinds of issues that are in crisis end up at the emergency room, which really is a symptom of the problem of not enough services. So if the committee decides to go forward and that isn't the direction you want to go, the idea of a legislatively determined one would be including legislators, as we always do, bipartisan, bicameral, and I would say would need to include representatives of the healthcare system, representatives who know about this issue from the emergency department point of view, and from the administrative point of view. That could be the same person. I think we do need behavioral health specialists in the same way that I just described. If you do decide to go forward and you do want a legislatively determined one, as we've always done, the president and the speaker would be assigning, but they always ask for input, who should be on the committee, not just titles, but specific people. So that's what I would expect to have happen. So either way, I think we need to make sure we have people who are on the ground, knowing what the situation is like and what, can dig in really deeply to the problem. My ask is that they develop a very specific plan that would be brought back to this committee for similar to other legislative work groups, or I would think the Children's Cabinet would make strong recommendations to the committee, and then it would be up to the committee what you decide to proceed forward with. But we know what's going on right now isn't working. We know we don't have what we need. We know we could do a whole lot more to prevent the crises that we're seeing, and we could do a whole lot more to meet the needs of those who find themselves in those situations, the kids who are there for weeks and months.
If I could do a follow-up.
Sure.
I like this idea in some ways, but I'm also aware of we had the children's behavioral health task force 2 years ago, year and a half ago, who had many of those stakeholders, including parents, on it. And what I've found is that those recommendations, we talked about this issue quite a bit. But some of those changes still haven't happened. So I'm wondering kind of what we can do to kind of lift that to the next level, because we had, a time limited work group around that. Some progress was made, but obviously not enough. I mean, this is still a problem we have, and it's a problem we've had for a number of years.
Right.
And many people have expressed their opinion on why that is, including myself, but also you and other people and parents and providers and all that. I'm wondering how do we raise this level even beyond that? Because I think there's the children cabinet kind of issue, and then there's a specialized work group. I mean, I think there needs to be something more than that, with more teeth or something. So I'm wondering.
I'm okay with that. I think the issue is it has to be seen as a priority. It hasn't been prioritized. We have a new committee. I think that the recommendations that come back, you have the power to say this has to happen. That's what needs to happen. So, you might want to be on the committee, on the task force. But it has to be seen as a priority, or it's not going to happen. It's been a problem for a long time, and it's a growing problem. I don't think it's any secret that it's a huge problem. So
right.
let's give it some prioritization and some teeth so that we do move forward.
Thank you.
Thanks for the question.
Thank you, Representative Madigan. Further questions? One from me. With regard to the data collection and the posting on a website, just talk a little bit, please, about how often the data would be updated and whether there would be any identifying data posted with regard to those impacted by this.
Thank you for the question. As I mentioned, this bill was presented last session, and as you heard just before this one, a lot of bills ended up being brought again because we didn't get to complete them. Dr. Tweed is one of the people I've worked with very closely on the bill, and we met last session with members of the department around this issue, and specifically around the data. The original ask was for more frequent postings, just so that it's, again, prioritization. It's raised to the level where people see it. But, as a social worker and clinician, confidentiality is my middle name. And it was very clear that the data, and data, I hesitate even to say data because it's numbers. It's what is asked for, specifically the numbers of kids who are stuck in an emergency for more than 24 hours. It would be, so what we came up with as a safe number was annually. It would be updated annually on the dashboard. It would be aggregated. It would be non-specific to hospital, to geographically non-identifiable, so that just like with other information, if you have a small community, you don't want to put that out there as public information when it isn't public information. It's purely to say this is a problem, but it's numbers. The work of the work group or the children's cabinet that I've proposed is to really dig into those numbers. What are the demographics? What are the ages of the kids? What are the diagnoses? What are the what's the coverage that they have or don't have? What groups of kids are more highly represented by diagnosis, but also by issues of income or race or all the factors that can contribute that we aren't zeroing in on. We need to know those things so that we can make a plan that is specific and will make a difference. And with some teeth, as Representative Madigan says.
Thank you. Seeing no further questions from the committee, we thank you for bringing this bill to our committee today and for your testimony.
Thanks, everybody.
Next, we have Dr. Todd Landry from the Office of Child and Family Services. Dr. Landry, welcome.
Good morning. In his absence, to Senator Claxton, to you, Representative Meyer, members of the Joint Standing Committee, my pleasure to be with you this morning. I'm Todd Landry. I'm the Director of the Office of Child and Family Services within the Department of Health and Human Services. And I'm here today to share our concerns about LD 118. As you have heard, this bill sets forth certain data collection and reporting requirements on children with behavioral health needs who remain in hospital emergency departments for extended stays. In addition, this bill would require OCFS to modify the role of existing children's behavioral health program coordinators. I want to start off by saying that OCFS agrees that children are not well served by waiting for the appropriate level of behavioral health care in a hospital emergency department. We recognize that this can have a negative impact on the child's well-being and present significant challenges for hospitals. However, we do not believe the steps laid out in this bill produce meaningful change on the issue. The expansion of the availability of services to address behavioral health care needs is the primary means by which change regarding this issue will be effected. The implementation of the changes proposed in this bill will have a significant impact on OCFS's Children's Behavioral Health Services Division. If CBHS staff must dedicate time and resources to collecting and reporting the data as required by this bill, that is time that cannot be spent building capacity within the system of care. OCFS staff are already working directly with hospitals and providers to facilitate the placement of youth out of emergency departments as expeditiously as possible. The data collection and some of the reporting requirements of this bill could take away from the time staff currently have to work directly with those hospitals and families. In addition, OCFS does still have concerns about the benefit of providing public reporting as required under this bill when balanced against the very small number and percentage of Maine children who experience an extended stay in an emergency department. There is concern that given the small number of impacted children, it may be possible to identify the children reported. OCFS does not believe that there is significant public benefit that would result from posting this data that would outweigh the privacy interest of these children. Additionally, OCFS already has staff within Children's Behavioral Health Services who coordinate services for children and families and assist in locating and securing placement in the appropriate level of care. Therefore, we believe Section 2 of the bill is potentially duplicative of current practice. As an alternative to this bill, OCFS would recommend continued efforts to focus on capacity building within the current children's behavioral health system, including both community-based and residential services. The goal of building capacity is interwoven into the children's behavioral health system improvement efforts, including establishing a psychiatric residential treatment facility in Maine, providing support to community-based services that may prevent the need for a higher level of care, and working in collaboration with partners on effective strategies to rebuild the children's behavioral health workforce. OCFS has also partnered with MaineCare to conduct a rate study for children's residential services, also known as PNMIDs. Although that rate study is not yet complete, DHHS has a placeholder in the budget proposal for an anticipated recommended increase in the rate for this service. A rate which is adequate to compensate for the costs of delivering the service is a critical step towards increasing both quality and access. OCFS is dedicated to its plan to improve the children's behavioral health system in a comprehensive and strategic manner through the identified improvement strategies. But this bill would have a potentially direct negative effect on the amount of time children's behavioral health staff have to dedicate to system improvement work. While OCFS currently works with hospitals on individual cases where children are awaiting an appropriate level of care in the emergency departments, it is not clear whether hospitals have the capacity and systems necessary to collect and report the data required in this bill. This may create additional costs for hospitals and could place an undue burden on them. This bill also contains no enforcement mechanism by which OCFS can compel hospitals to report the required data. Any reporting of this data required of OCFS could be negatively impacted if hospitals were unable or unwilling to provide the data. Within CBHS, the Children's Behavioral Health Service area, OCFS is primarily focused on building capacity and improving the quality of services. OCFS believes that improvements in both of these areas will have a positive effect on the number of children who must wait for the appropriate level of care in emergency department by reducing that number. We will welcome opportunities to work with the committee on efforts to build capacity, but we believe this bill would not have any impact on capacity and instead could take staff time away from system improvements efforts already underway. I thank you for the opportunity to testify today. I will note that I was on the legislative work group that was referred to before in 2019. I'm happy to provide comments and thoughts on that and how those recommendations have been built into the children's behavioral health strategies, as well as answer any questions that you might have.
Thank you, Dr. Landry. Questions from the committee? Yes, Representative Javner, go ahead.
Thank you, Madam Chair. Dr. Landry, thank you for being with us this morning. I have 3 questions. So the first question is, how many children are impacted? And maybe we don't have exact numbers, but an average per year. Also, number 2, I think we've heard the rate study would be complete in the end of February. Is that still on track? Do we know? And the capacity level issue, what is your capacity right now? What would be the ideal capacity? And do we know what that would cost?
So let me try to take those in order that you gave. So thank you for asking them. One of the differences between this year and last year is last year when a similar bill was introduced, I would not have been able to share with you what that data was. Beginning just over a year ago, I requested my staff to begin issuing to me, as well as other members of our team, weekly reports on exactly this information. Those weekly reports include the number of children, the specific hospital where they are, the diagnoses, as well as the efforts made and planned in order to help facilitate those children or youth to move out of the system. We have that data. I can tell you without violating confidentiality that the average number of those reports indicate the average was 3 children over the course of the year that were waiting in an emergency department. There was a range, but in all but 1 week of the year, that number was never more than 10. So again, it ranged. I can't really go into more specifics. We have the data on a weekly basis. The reason we don't put it out there is with such a small number, it would potentially violate the privacy of those individuals, which we don't think is right for them. So again, the average number of those weekly reports over the course of the entire year of 2020 was 3. Regarding the rate study, I will need to get more information from our colleagues in OMS, who are taking the lead on the rate study. We're helping and supporting that work. I know that we have received input, I believe, from all but one of the providers at this point. That input was due at the end of January, but we're still waiting to get the information from all of them. I believe that does put us on track to have that rate study potentially completed by the end of February as we had anticipated. As I indicated before, I think this is an absolutely critical component towards us moving our system forward. That rate, to my knowledge, has not been adjusted in over 10 years. Obviously, costs have changed in that 10-year time period, Quality standards have also changed in that 10-year time period, and we want to update the appropriate standards for those from a quality perspective as well. But the rate and the quality do go hand in hand from that perspective. So I believe we're on track with my colleagues over in OMS. We can confirm that to be the case. And then the last question, when you talk about capacity level, I'm curious, are you talking about capacity level as far as staffing capacity? Or are you interested in bed capacity? I'm not sure which type of capacity you might be interested in.
I apologize, staffing.
From a staffing perspective, one of the areas where I know that we have, I've mentioned this before the committee, and I would tell you, and I don't have a direct dollar number, it's not one of our budget initiatives, but one of the challenges that we have is the fact that when you look at the area of quality assurance is an area where the department, I believe 10 years ago, had a team within Children's Behavioral Health Services alone of 8 to 10 staff. And those 8 to 10 staff were focused on working with providers, following up on quality inquiries, ensuring the right training and resources were available to providers. In 2016, I believe that unit was completely dismantled. And so we, as of last year, or a year and a half ago, when I came into the department, into this role, we had 0 quality assurance staff. We are now fortunate through the $8.5 million 4-year federal grant that we received that we are going to be able to reinstate 3 of those positions. And hopefully that's a step towards building in the future, because I think we also have to focus on quality and support for the providers to ensure that the services that are being delivered are getting the results that we want. We all know that's critical. If it's not working, we need to be able to change and be able to work with providers to change those services. That's all part of capacity building. It is part of that 4-year, $8.5 million federal grant that we just received and just were able to kick off. So we're in the very early stages of that. But that's a good example, I believe, of the kind of capacity building that we're looking at implementing within the state. And fortunately, we're able to do that using federal dollars through that federal grant.
Thank you very, very much, Dr. Landry. We appreciate that.
Thank you. Any other questions from the committee for Dr. Landry? One from me, Dr. Landry. I'm surprised at the report of only three children impacted by this from your collection of data. Am I correct in? Did I hear that correctly?
It's a week. That is a weekly average of the number of children.
Weekly average. Okay.
Yes, ma'am. So that's a weekly average number over the course of 2020. So if I wasn't clear about that, my apologies.
Okay. Thank you very much for that clarification. And who at the various hospital systems is reporting that data to the department?
Mm-hmm.
Who's the designated reporter?
Yeah, it varies by hospital. In some cases, that duty is assigned to the supervising physician in the emergency department. In some cases, it's assigned to a clinical social worker that's in the emergency department. For some hospitals, they may only have one of these situations over the course of the entire year. So it's whoever happens to be on duty and assigned for that task. Other hospitals have dedicated staff that are assigned that on an ongoing basis. So it really depends upon the capacity of the staff and the ability of their own processes on who actually does that reporting. That does sometimes add to I guess just one of the questions and concerns we have. The data collection piece of this is all dependent upon the hospitals being willing to share that information. Just as the other information I just shared with you, it's the same piece of voluntary information that the hospitals are providing to us. So again, we have all of the data that you're looking for, that you've asked for, and that I believe the Representative McCray suggested. I think the challenge is we are not going to be able to publish that information publicly, but we have that information, and it certainly has gone into some of our improvement efforts, such as the PNMID rate study, as we began to identify and collect the data on this. I would also just very quickly mention I don't think there was a question on it, but since it came up before, I hope you'll give me the latitude. Regarding the previous legislative workforce that was created, Senator Claxton is back, I see. And so Senator Claxton actually co-chaired that, work group. The work group met over many months, several times during the months, the second half of 2019, invested, a number of hours of staff time, families, advocates, physicians, and others around the issues around children's behavioral health. And so I would certainly refer back to Senator Claxton. I don't recall, I should say, if a report was ever published as a result of that work group. However, what I can tell you is we took the information from that work group and immediately built that into our children's behavioral health improvement strategies. The update on those strategies was provided to all of you in the fall of last year, I believe in October and November, and I would certainly be happy to review that with you as a committee if that's something that you're interested in.
Thank you, Doctor. Up next in the queue is Jan Collins. Jan.
Greetings, Senator Claxton, Representative Meyer, and honorable members of the Health and Human Services Committee. My name is Jan Collins. I'm an Assistant Director of Maine Prisoner Advocacy Coalition. I am here to support LD 118, an act to address Maine's shortage of behavioral health services for minors. MPAC's purpose is to reduce Maine's use of incarceration by creating a criminal justice system that is ethical, humane, and restorative in nature. Encouraging the development of community resources that treat people with mental illness in the community, not jails, is a priority. Keeping youth with mental illness out of the criminal justice system is number one. The connection between serious mental illness and incarceration has long been known, with statistics varying between 37 and 40% of inmates suffering from one or more conditions. If we include substance use disorder, the statistics only rise. We see similar statistics in youth. In 2017, a Cutler Institute Place Matters report found that 29% of youth at Long Creek came directly from residential treatment. Using WebMD to search for child and adolescent psychiatrists serving my community in Franklin County, I find a response of 0. When I increase the distance to a 100-mile radius, there are still no child psychiatrists. Using the search tool from Psychology Today, we find a total of 1 child and adolescent psychologist in Maine and 6 nurses, mostly clustered in southern Maine. No wonder then that when I talked with a nurse in charge of the emergency department in our local rural hospital, asking her what her number 1 issue was, she did not hesitate to respond, lack of mental health beds. She then proceeded to spend at least 30 minutes explaining the impact on our very small hospital of having 1 or more patients unable to leave the ED for lack of psychiatric beds in Maine. I understand that this bill will only collect data, and I understand why, but it saddens me that the suffering of our youth and mental health crisis will continue for at least 2 more years because we have decided that a lower tax rate is more important than their ability to receive health care. Please support LD 118, an act to address Maine's shortage of behavioral health services for minors, or better yet, do something concrete to increase the availability of mental health beds in Maine. Thank you, and thank you to Representative McCrate for bringing this bill forward. Are there any
Thank you,
questions?
Ms. Collins. Questions from the committee? Seeing none, thank you for being here today.
Thank you.
Jennifer Jewell. There she is. Good morning.
Good morning. Senator Claxton, Representative Meyer, distinguished members of the Joint Standing Committee on Health and Human Services. I am Dr. Jennifer Jewell, a hospital-based pediatrician, a member of the Board of Directors of the American Academy of Pediatrics Maine chapter, and a resident of Portland. I am testifying in favor of LD 118. We can all agree that the best way to inform healthcare system changes is to collect and analyze accurate data. Then we can develop and implement the correct healthcare solutions, and we are able to assess the future impact and results of these solutions. In addition, we can all agree that extended stays in emergency departments for youth with behavioral healthcare crises are inappropriate, delaying needed care and negatively impacting youth, their families, and caregivers. LD 118 addresses the gap in data for youth in behavioral healthcare crisis who are waiting in emergency departments for needed psychiatric care. Youth and their family or caregivers seek crisis behavioral care in emergency departments at the height of their distress. They need comfort, care, and a plan for problems that have often been percolating and plaguing them for years. The role of emergency departments is to assess them medically, making sure no urgent medical care is required, and then to alert behavioral health care experts of the need for urgent behavioral health care evaluation and treatment. Ideally, youth in need of intensive behavioral care then are transferred to the appropriate psychiatric provider, including admission at psychiatric facilities when warranted. Over the last several years, increasing numbers of patients are spending days, even weeks, in emergency departments awaiting placement at psychiatric hospitals. Our emergency departments are designing behavioral health wings to accommodate these longer holds so families have easier access to amenities such as kitchenettes. And these emergency department remodels are happening more and more. This is not a solution for youth with intensive behavioral health care needs, their families or caregivers, or for emergency departments. Rates of depression and other behavioral concerns in adolescents have doubled over the last decade. As these numbers increase, we are seeing these youth in our offices and emergency departments. However, we are not systematically collecting and tracking statewide data, such as how many and how long youth who require urgent psychiatric hospitalization are waiting for appropriate and available services. Without this information, we cannot understand completely how often our young patients in Maine are waiting in emergency departments for urgent care, and we are unable to plan appropriately for addressing the full breadth of behavioral health care needs of the youth in our states. I'll just add to my testimony that I totally appreciate and agree with Representative McCrate's analysis and comments on this. And just want to say it's for all these reasons that I support LD 118. Thank you.
Thank you, Dr. Jewell. Questions from the committee for Dr. Jewell? Seeing none, thank you for being here today.
Thanks for having me.
Sure thing. Liam Shaw, please.
Good morning, Senator Claxton, Representative Meyer, and the members of the Joint Standing Committee on Health and Human Services. Thank you for the opportunity to speak to this legislation on behalf of the Maine Children's Alliance. My name is Liam Shaw. I live in Gardner, Maine, and I am a member of the Board of Directors for the Maine Children's Alliance. I'm here today to testify in support of LD 118 in an act to address Maine's shortage of behavioral health services for minors. I've been a licensed clinical social worker in the state of Maine for 24 years. For the first 20 years of my social work career, I worked predominantly with children in the treatment foster care system. As you would imagine, children who require the higher level of service that treatment foster care provides also tend to require more frequent contact with children's crisis services and subsequently more trips to a hospital emergency department for mental health and behavioral health emergencies. Over that 20-year time period, I personally spent hundreds of hours in hospital emergency departments supporting treatment foster care children and their treatment foster care families. On many occasions, the treatment foster care child would be confined to a hospital emergency department for weeks on end, and so I was able to personally observe the negative impact that these extended stays had on both the children and on the families and caregivers who are attempting to support them. While our hospital emergency departments do a great job of keeping children safe, during this time, the child typically does not receive any evidence-based treatment to address the underlying issues that brought the child to this level of crisis. In my experience, no one benefits when a child is in a hospital emergency department for multiple days. Unfortunately, it's truly a lose, lose, lose situation. The child loses because they're not able to receive evidence-based treatment. They're scared, overwhelmed, and are not in a child-friendly environment. The family and caregivers lose because they know that their child would be better served by evidence-based child and family-focused crisis services that are provided in the child's home or in some other child and family-friendly environment. And finally, hospital emergency departments lose because that child's extended stay uses up significant staff time, ED space, and resources that could be devoted to a more traditional acute medical emergencies. Having Maine's children needlessly stuck in emergency departments for extended stays is clearly a problem that we need to start to solve. Maine's Children's Behavioral Health Services that Dr. Landry referenced released a logic model in 2020 that detailed 3 long-term outcomes that they hope to achieve. The second outcome listed on this document states, and I quote, "the right services at the right time for the right duration," end quote. I fully agree with this goal, and it is my belief that the passage of LD 118 will go a long way towards allowing CBHS to gather data and measure the exact frequency and duration of time that Maine's children are spending in hospital emergency departments across the state. To put it simply, we need the hard data that will help us understand exactly how long the children in the state of Maine are spending in extended stays in hospital emergency departments so that we can start to formulate a plan to address this weakness in our children's mental health service. I urge the members of this committee to pass LD 118 and to provide Maine's Department of Health and Human Services with the resources necessary to start to gather data on the number of children with mental health and behavioral health needs remaining in hospital emergency departments for extended stays. I believe that the passage of this bill is crucially important and that it is a critical step in solving the current crisis of children being needlessly confined to hospital emergency departments instead of receiving the effective evidence-based mental health treatment that they deserve. Thank you all for your time, and I'm happy to answer questions.
Thank you, Mr. Shaw. Questions from the committee? Yes, Representative Madigan.
Thank you. Thank you, Liam, for being here. Good to see you.
Okay.
My question is about, we've talked a lot about the children waiting in the emergency rooms and the lack of hospital beds. As also a social worker, I tend to think of what happened before kids get to the emergency room and what are the services that are missing that could have prevented this from happening in the first place and prevented a hospitalization or residential stay. So I'm wondering kind of if you could speak to the usefulness of this bill towards us knowing kind of where and what kind of community services we need.
Yeah, it's an excellent question. I agree with you. I personally and professionally would much rather intervene before children get to this point. We certainly do need adequate number of psychiatric hospital beds in the state of Maine, but I think you could also make an argument that the investment can be made in community-based services as well. For me, I really feel like before I can fully, answer a question, I really need to understand the data of the problem that I'm looking at. Like I said, I personally spent nights sleeping in the chairs in the rooms with kids, survived on crackers in 12-hour shifts and things like that in an emergency department while I was supporting families. So I have my own personal experiences with that and my own, professional feelings about how I didn't really feel like it benefited children in any significant way other than keeping them safe. But my desire would be to have the data that we could really gather and analyze, and to make sure that we fully understand this issue. And I understand Dr. Landry, who's a wonderful guy, is concerned about diverting resources, and I understand that hospitals are overwhelmed and may or may not share the data. My experience, limited that it is that hospitals don't want these kids stuck in the EDs as well. So they might be a willing partner in gathering the data. So I think we need to gather the data, and we also need to have discussions about being proactive and trying to figure out what brought these kids to the ED at this time, and how do we go backwards and figure out what services could have helped and maybe even prevented them from having to access this service. I hope that answered your question.
Representative Perry.
Thank you. The question I have, and because you have worked with these children in the hospital, is do you sense that this is another trauma for a child that's already traumatized?
That is an excellent question. And I'm a person professionally, have spent 24 years working with kids who are traumatized, part of a program that recently received a 5-year grant from the National Child Traumatic Stress Network. So trauma is something that I spend a great deal of time thinking about. I think that it is safe to say that when you confine a child to a small room with maybe a TV, maybe not, security guards around, and limited access to social engagement, limited access to treatment, limited access to anything, literally, it has a negative impact on that child. Now, whether it bumps over into trauma there's a lot of debate about the definition of trauma and things like that. And so some people would say that has the potential to be traumatizing. Other people would say, that it's significant, but not necessarily bumps into trauma. I think anybody, regardless of their definition of trauma, would agree that if you have a child confined for an extended period of time, especially weeks, without receiving services, significant services, that child's not benefiting, other than the child is remaining safe and maybe not harming themselves and maybe not physically assaulting people. That's the only benefit, but they're not really receiving treatment that's addressing the underlying issues. So it's certainly significant, and in the worst circumstances probably would be considered potentially traumatizing.
Thank you. Representative Madigan, do you have another question? Any other questions for Mr. Shaw? Seeing none, thank you for being here today. Mary Jane Krebs, please.
Good morning. Excuse me, Senator Claxton, Representative Meyer, and members of the committee. I'm Mary Jane Krebs. I'm an advanced practice psychiatric nurse by background. I'm currently president of Spring Harbor Hospital within Maine Health, and I'm here to testify in very strong support of LB 118. Every day, our local health systems are challenged by large number of children and adolescents who are stuck in emergency departments for long periods of time, sometimes weeks at a time, awaiting the next appropriate level of care. Unfortunately, due to a lack of resources and staff, Maine simply does not have the continuum of residential, high acuity, secure residential, and community-based treatment options that are required to support our growing needs. Last year, more than 100 children with behavioral health needs languished in our Maine Health emergency departments for longer than 1 week awaiting placement. It's critical to understand this is not good, nor is it safe patient care. These children are living, as you have heard, for days and weeks in rooms that are very small, they're windowless, they're sterile, lights are on all the time, they're in noisy EDs. This is highly disorienting. They're also exposed to acutely ill behavioral health adult patients who oftentimes are very, very frightening. I'm going to share one story with you that was just so heartbreaking. At one of our local health systems recently, they cared for a child who was in the emergency department for weeks. She had been living in a group home for a number of years, but that group home felt they can no longer care for her and that she needed to go. She ran away. She was brought to the ED, After a couple of days, the staff were able to stabilize, set up some structure for her, give her activities to do. The group home refused to take her back even while they looked for alternate placements for her. But after a couple of weeks, she began to really struggle. It was December. She was worried that Santa wasn't going to be able to find her. She regressed terribly. She was having difficulty sleeping. She began wetting her bed. So the staff set up a small Christmas tree in her room. They wanted her to be able to wake up on Christmas morning with gifts under that tree so that she had somewhat of a normal Christmas celebration. They tried to make the best out of a truly horrible situation. And finally, at the end of December, a bed opened up at Spring Harbor and she was able to be admitted there. Unfortunately, our EDs are often viewed as safe holding spaces for children like this little girl, and they are not. This shouldn't have to happen. Because of the appropriate resources that are not available for these children, they often do feel forgotten. They become hopeless, they give up, they regress, they become violent towards themselves and others. They really struggle with being in these environments, feeling abandoned. And like this little girl, there are many children who come into the ED.
Excuse me, 30 seconds, please.
Pardon me?
30 seconds.
Okay, sorry. So the flip side of this is that children are stuck at Spring Harbor Hospital. We have the same issues there where children are languishing for months awaiting placement in residential sites. The system is broken, and currently we have 4 patients at the hospital with 298 days for residential placement. So the beds that they're taking up are not available for children in the EDs. We fully support Maine Health is supporting LD 118. We think that we need to look at this data. We need key stakeholders involved. And we really need to finally be able to have a therapeutic continuum of care for our children who are most vulnerable in the state. Thank you. If you have any questions, I'm happy to answer them.
Thank you for your testimony. Questions? Yes, Senator Baldacci.
I just wanted to thank Ms. Krebs for her testimony and also for her work and leadership. But this is a really important issue, both in all parts of the state. I'm concerned about, children being left at emergency rooms without beds. In terms of, do you have any kind of way that you gauge how many calls you've gotten that you could not accommodate of minors who are at emergency rooms during the course of a year that you could not immediately accommodate?
So, great question. We are more and more able to track that data. And what we're trying to understand is what level of care do they need? And is it that the hospital beds are tied up? So we're trying to collect that data on both ends. So yes.
I just think that would be helpful data to share with us as well, because I think that it was testified previously, and I can totally concur that we have a lack of mental health beds in the state, psychiatric resources in rural settings. So it would be helpful to know, because they're in the emergency room because there's a crisis. Correct. And they're in a personal crisis, and that is really the moment, we need to have resources in order to help them not kill themselves or not engage in other episodes of self-harm. So I'd be very interested in the data about emergency room requests that could not be immediately accommodated, not just from your hospital, but I'd want this from Eastern Maine, from Northern Light as well, just to have an idea of what the acute issue is, because that's one of the really troublesome parts of this whole system. But thank you very much, really, for your work. I know this is not easy, and appreciate your time today. Thank you.
Thank you.
Thank you, Senator, and thank you, Ms. Krebs. Next is Michael Kabidi. Michael, welcome.
Thank you, Representative Mayer, Senator Claxton, and members of the committee. Good morning. My name is Michael Cabeda, and I'm Policy Counsel for the ACLU of Maine. On behalf of our members, we urge you to support LD 118. This bill would help make Maine take a step, a small step, but a crucial one toward healing our young people who struggle with behavioral health challenges. This bill would change two things in our current system. First, it would require hospitals to submit certain data about extended youth stays to the DHHS. And second, it would require DHHS to make an annual report about that data and propose solutions. Both these changes, modest though they are necessary to divert youth away from our criminal legal system, where untreated behavioral health problems play an outsized role. According to perhaps the most rigorous study about juvenile justice ever conducted in the state of Maine, well over half of incarcerated youth in Long Creek received behavioral health services through Maine Care the year before they were committed. 71% of that group received the most intensive form of behavioral health services. For too many Maine children, the juvenile justice system has become the default provider of behavioral and mental health services. This bill would help remedy this problem by strengthening our knowledge of what happens upstream before a young person gets involved in our criminal legal system. Dr. Landry suggested that this bill would expose youth to a violation of their right to privacy by making it easy to find out which youth information was shared publicly about. I think that the deprivation of liberty that might result downstream if these problems aren't studied and understood poses a greater violation of legal rights, and the deprivation of the right to privacy that often goes hand in hand with involvement in the criminal legal system is a risk that this legislature has to weigh against the potential violation of the right to privacy in healthcare law. This bill offers modest common sense reforms, and we urge you to vote that it ought to pass. I'm happy to try and answer questions if you have any.
Thank you, Mr. Cabeda. Questions from the committee? Seeing none, thank you very much for your testimony today.
Thank you.
Mallory Shaughnessy, welcome.
Good morning, Representative Meyer, Senator Claxton. Yep, back again.
Mallory, we've got some audio issues with having a hard time hearing you. Not much better. Do we? Do you want to try and go out and come back in?
Yeah.
Okay,
Yeah.
we'll come back to you. So Lisa Harvey McPherson, I believe. Yes, there she is. Lisa.
Yes, good morning, everyone. Senator Claxton, Representative Meyer, and committee members. My name is Lisa Harvey McPherson, and I'm here today to speak in support of this bill on behalf of Northern Light Health. Every day, a Northern Light Health member organization has a youth in our emergency room for extended periods of time in need of behavioral health services. And the scenario is very typical. A foster parent or a parent or perhaps someone at school dials 911 and the child is transported to our emergency room. But we've also had occasion where the Department of Health and Human Services directs that child come to our emergency room for evaluation and placement. We do evaluate the child and we stabilize them. Very often telepsychiatry support from Acadia Hospital is involved. And now the child is stable and ready for discharge. And then our doctors and our nurses and our social workers and our care managers fail that child every day because we cannot find the services that they need in the community. And despite the compassionate work of our emergency room personnel, this is not where children need to be. Emergency rooms are loud and they're scary and they're sterile. And because of COVID-19, this child is placed in a room and they can't leave that room. They're stuck. They only receive the bare necessity of services that an emergency room can offer: medications, daily evaluation with Acadia. This is not a behavioral health treatment plan. And they're stuck. No community residential facilities available. There are no community resources available to meet their needs. And we attempt to provide educational supports. And if their school, their local school has a structure, we participate with that school for the education that they need in the emergency room. But very often we're trying to find a school system to work with us. And then the local school in their home community disputes our plan. Now, when services become available, these kids are sent all over the state. Kids from Portland go to Fort Kent, kids from the county go to Southern Maine, kids go to Acadia, they go to Spring Harbor. But very often what they really need is residential treatment, and that's the most difficult placement to find. In preparing testimony, I did a query of our hospitals, and sometimes, a big system, it takes a while to gather information. I had responses right away from all of our emergency rooms. The kids that we identified for this hearing, they were 9 to 17 years old, and kids have been in our emergency rooms from 5 days up to 77 days waiting for services. And on any given day, we have 12 to 14 children in emergency departments in Maine waiting for admission to Acadia Hospital. Acadia is also challenged. They have long lengths of stay because of the lack of residential treatment beds in the community. So we are in absolute support of having the Children's Cabinet take this issue on, or a legislative group to coalesce around and finally proclaim that this is unacceptable for our youth and we must solve this problem. I understand that there's a data component. I think there's value in data, but we need to shine a light on this and resolve this. And I will share with you, after I put together my testimony, I had emergency room doctors and nurses reach out to me, thanking me that there was going to be hope that someone would hear them. And so I also want to share that with you. Thank you.
Thank you, Ms. Harvey McPherson. Representative Zager has a question.
Thank you, Madam Chair. Ms. Harvey McPherson, I appreciate your testimony, and I was hoping that you might help illuminate from a hospital system perspective the concerns raised earlier about whether hospitals would fight the providing this data for medical legal reasons or other policy reasons. And also if you could comment on the data transfer, how easily with electronic medical records and human interfaces, if that information could in an efficient manner be transmitted to the department.
So we have the data now. By and large, these children are interfacing in some way, shape, or form with a referral to Acadia Hospital. So we have the data now. It's not hard for us to collect the data. In terms of sharing data, clearly data would be de-identified. And I think there is a level of protection that when data is mandated to be provided to a state entity in a de-identified way, we're complying with the law.
So it sounds like you, in one of the largest hospital systems in the state, don't see any problem in either of those concerns.
No, I don't.
Thank you.
Okay. Senator Baldacci.
Thank you. Thank you, Ms. McPherson, for being here. Thank you for your leadership. It's very important. We've heard some compelling testimony, but what was particularly compelling in what you had to say was that every single day of the year, there is at least one child who is kept in an emergency room because for the lack of beds. Is that correct?
Correct. And it's important to understand the nuance of that. It's not always a new child, but when we have a child in an emergency room for 77 days, when these kids have extended periods in the emergency room, those days add up.
So one of the questions I asked Ms. Krebs, so I'll ask you as well, is just that it would be helpful just to have the information as to numbers. I don't, obviously, that's all that we really need is numbers in terms of the number of children each year And the length, I understand there's a length of stay, but I'd like to know how many children, for instance, have to be housed in an emergency room for, say, more than 4 or 5 days. It'd be helpful to have some context in that information if you could provide us at some later point. Thank you very much.
Thank you. I apologize, my phone's ringing, but.
Thank you, Lisa.
Okay,
Oh,
thank
I'm
you,
sorry. I'm sorry. We do have another question from Representative Connor.
Thank you, Madam Chair, and thank you for coming in and giving us this testimony. I'd like to get some data in reference to Senator Baldacci. Like him, I like to see the data. And you had mentioned, children from the county going south and children from south going to the county. I would like to see some hard data on that as well. I'd like to know how many are actually being traversed across the state for service, if you could provide that.
Okay, I can ask. Yep.
Thank you, Madam Chair. That's all I have.
Thank you. I see that Ms. Shaughnessy has rejoined us. Let's try it again, Mallory.
Okay, can you hear me now?
We can.
Great. All right. Good morning, Representative Meyer and Senator Claxton, members of the Committee on Health and Human Services. My name is Mallory Shaughnessy, and I live in Westbrook, and I'm the Executive Director of the Alliance for Addiction and Mental Health Services. I am here on behalf of the Alliance and in support of LD 118, but I am going to change up my testimony a little bit from what you have, given some of the comments that have already come before us and the testimony from Office of Child and Family Services Director Todd Landry. But I do want to make a couple of key points. We at the Alliance, and I have to say too, there may be noise coming from another room in the house. Kids are getting very rambunctious, my grandkids. So don't mind that. They are being taken care of. The Alliance and its members agree that good data is critically important to inform our system of care and to base our policies and our initiatives on. And it sounds like the Office of Child and Family Services has been moving this information together and pulling this information together, which we commend. I think Todd is doing a fabulous job over there. We also heard, though, that the amendment about the Children's Cabinet being engaged in this process and reviewing and tracking of data and reporting on that. And we would support this in the sense that it would be a way better fit to bring together and break down some of the silos of the systems that our youth move through. I do want to point out that emergency departments are not the only place that our children get stuck. As referenced earlier, and I highlighted some of the data from the Maine Juvenile Justice System Assessment, many children get left at Long Creek. And over half of the kids there are there because there was nowhere else to provide them safe services. And that is a tragedy, as well as being stuck in the emergency rooms for, weeks on end. Both of these things need to be looked at. They need to be combined together, and we need to review that as well. We also need to look at the data that they're already collecting in Office of Child and Family Services about the number of children on wait lists for those home and community treatments for behavioral health challenges and mental health challenges. And those stuck out of state, we have, I think, up to 70 children now out of state in residential placement because we didn't have a place here for them, many very far from home, I think as far as Utah. So it's a real problem, and there are many pieces of it that all need to be brought together and looked at as a whole so that we can really see what we need to do for the system. Quite often these children are escalating into crisis, into the emergency department and in collision with the correctional system because they just don't have the appropriate level and supports of treatment that they need in the community. So we wholeheartedly agree with Director Landry that what we need is investment in the capacity of the community-based system of care in our children's residential treatment. We already know this is in dire need of additional resources, and there will be a bill before you soon that specifically addresses this issue. I'd like you to look out for it.
30 seconds, Ms. O'Shaughnessy.
Yep, I'll wrap up. One other note that I would like to leave you with is just a thought to think about is that we are an outlier in Maine, and that we are one of the only states left that do not merge their children's juvenile justice and their child serving health and human services departments together so that we can fully look at these pieces all together all the time. So just to plant that seed for future thoughts. And I thank you very much for your attention to this issue. And I thank Representative McCray for bringing this issue forward. And I'd be happy to answer any questions and get material for you for the work session.
Questions for Ms. Shaughnessy from the committee? Seeing none, thank you, Mallory.
Thank you.
So I see no additional signups. Do we want to take a few minutes in case there are any late comers? So another 5 minutes, perhaps? Return at 11:05? Okay.
Okay. Okay. Call. Call Tidewater Telecommunications. Look up Tidewater telephone.
Holly, for some reason, you're not on mute.
Welcome back. It's my understanding we do have Mr. Jeff Austin.
Good morning.
Hello, Jeff. Good morning.
I apologize for being tardy on this bill. I was in the Insurance Committee Zoom room opposing Senator Claxton's legislation. I had to follow him over there, and I'm now back.
Well, welcome.
I appreciate, I have missed the testimony on this bill, or most of it. I appreciate that you've taken this much time on it. I will be quick. I saw the beginning. I saw Representative McCrate's testimony, and I would just add this if it's not been drilled down on. We do think there is a big distinction between a legislative work group and a directive to the administration. The amendment that Representative McCrate offered to have the Children's Council come up with a plan, we think is a much better approach than you yourselves taking on the task of coming up with a plan. It's just hard for third parties like us or the legislature to tell an administration how to do something on a day-to-day basis. This is a day-to-day issue. We really think it would be better if the administration had to put forward the plan and then you comment on it. It might seem like a tomatoes issue. I really don't think it is. That fundamental difference. I don't know how further you went into that discussion with the department. I apologize if you advanced the conversation beyond when I had to leave. But I would not merely view that as two sides of the same coin. They do this stuff day to day. I think they're devoted to it. I don't think they don't see the issues that we do. I think they work hard on it, but I think it would be better that they come forward with something about how this is all supposed to work, as opposed to you telling them what you think, as opposed to how it's supposed to work, with all due respect. With that, I'll wrap up, and I appreciate you letting me sneak in here late.
Absolutely. Questions for Mr. Austin from the committee? One from me, Jeff. I wonder if you could comment on the problem, on how widespread the problem is statewide within our hospital systems.
We hear about it a lot. I think there's a little distinction in which hospitals feel it more. There are 7 community hospitals that are licensed to provide psychiatric services, although only 2 of them are for children. And you'll hear about this in the biennial budget next week because they're both cut. But it shows up in every emergency room. There's no geographic confinement for where a child can be in crisis. And sadly, where do people turn? They either turn to the police, please help me address the situation, or they bring them to the emergency room. And there are some real heartbreak stories where family members leave their children, leave their grandchildren. Happens a lot with grandparents. I can't do it anymore. I can't handle the child anymore. And so that's another hidden crisis. It's at least a little visible in an emergency room. I live in Brunswick, and we had a case where the family called the press to have a press conference about it to try to draw attention. But the hidden issue is all the families struggling to hang on at home. And that's very difficult to get your handle on. It is only when it gets so far that they show up in the emergency room or they call the police that you can quantify it. How many families are out there struggling white knuckle right now to keep the kid at home? So it is out there. I think sometimes it works smoothly. They can get the kid the services and it can resolve quickly. Other times it doesn't. And those are the ones that I don't know if you heard this either, but can really be stressful on staff. Is he still here? Is Jeff still here? And you can just see staff get deflated. Yep, he's still here. So I appreciate the opportunity to testify.
Thank you for being here. Carrie Bickford, please. Ms. Bickford? Carrie Bickford? Here she comes.
I appreciate the opportunity to testify.
Good morning, everyone.
Thank you for being here.
I am so sorry about mine.
Carrie Bickford, please.
Hi. Good morning.
Do you have, 1 second, do you have the YouTube running simultaneous to your appearance here?
I might.
Carrie Bickford?
Dwayne.
Here she comes.
Dwayne.
I appreciate the opportunity to testify.
Dwayne. Good morning, everyone. I am so sorry about mine.
Carrie Bickford, please.
Good morning.
Do you have, 1 second, do you have the
Yes.
YouTube running simultaneous to your
Dwayne.
appearance here?
I might.
Carrie Bickford?
Dwayne. Dwayne. Good morning, everyone.
Carrie Withy, any suggestions on?
Can you hear me?
Yes, we can hear you. I believe you must have the YouTube video open on your browser.
I do, and I'm trying to find it. Oh, boy.
I'll mute you in the meantime. I think if you minimize the Zoom and then open up your internet browser, you should be able to find the tab that has the YouTube video playing.
It should also include a little bit of a speaker emblem as being active.
I want to thank everyone who is tuned in for your patience as we hit just a small pothole in the road here. Is Miss Bickford still with us? I'm not seeing her on my screen.
Representative Meyer, it looks like she closed out of Zoom entirely.
Okay. Give her a few seconds to get back in. She back in?
Not yet.
Okay. Representative Javner, did you have a question or comment?
Yes, thank you, Madam Chair. Excuse me. Is it possible for me to ask a question right now about more information that I would like for the work session while we wait for Ms. Bickford?
I think so. Go right ahead.
Okay, I would like further information about the 70 children that we heard are being treated out of state. If we could get some data on that for the work session, I would appreciate that.
Thank you, Representative. I'm thinking that Ms. Bickford is continuing to have difficulty. And I would ask that she submit testimony, which she and anyone else can do right up until the point that we are working this in a work session. So we will look forward to that. I'll just check one more time with Ms. Withy. Is she's not returned? Okay. So unless, okay. Any information for the work session that our committee members would like to request? Seeing none beyond what Representative Javner has asked for, I'll close the public hearing on LD 118 and turn to Senator Claxton at this time.
So at this point, we're done earlier than we thought we might be. Is there other things that we need to be doing, Anna, before we think about taking a break or moving to a new agenda item?
For these bills, I don't have anything else. I know we did ask the folks who were going to present a couple of reports this afternoon if they might be ready this morning. I don't know if you want to do that or not.
One of the other options for an agenda item, though, would be to go to work session on the breast milk bill. And I'm looking for a general sense of the committee, whether the people feel like that makes sense or not. Nodding heads or a thumbs up. We don't have to do it now. I see some nodding heads. Representative Javner? Your head's not nodding. Do you have a thumbs up or a thought about that?
Yes, I am in full agreement if we choose to go into a work session. Thank you.
Okay. Anybody opposed? I don't want to make this happen if people aren't ready to discuss it.
Shall I go ahead and make the motion, Senator Claxton?
If you would,
Okay.
Senator Moore.
I would make a motion that we go into work session for LD 70, no, let's see, 85 at this time.
Do I have a second? I see several seconds. We're good for that. Okay. Do we want to go around and share thoughts? Does somebody want to make a motion? I defer to the committee. Were there unresolved issues related to this bill for anybody?
I would move to ought to pass this legislation
As amended?
as amended. Yeah.
And Representative Javner?
I apologize. I just want to make sure that we are very clear on what that amendment is.
Okay. Does somebody want to restate the amendment?
So
Please, Representative Craven.
thank you. So the department sent over the definition of the TRICARE coverage for donor milk. And so to be eligible, number one, an infant must have one or more of the following conditions: born at a very low birth weight, gastronomical abnormalities, metabolic digestive disorder, or recovery from intestinal surgery, which when digestive needs required additional support, diagnosed for failure to thrive, not appropriately gaining weight or growing, formula intolerance with documented feeding difficulties for weight loss, infant hypoglycemia, low blood sugar, congenital heart disease, pre or post organ transplant, or other serious health conditions when the use of banked donor milk is medically necessary and supports the treatment and recovery of the infant. And number two, the mother's milk must be contaminated, unavailable due to a medical or physiological condition, or available but lacking in quantity or quality to meet the infant's needs.
So the intent is to remove a subset of children who are covered, but who might be covered by TRICARE based on those standards from the department having to pay for the milk.
It was my understanding that those that those requirements would be included in our bill.
Okay.
If it's helpful at all, I can pull up the amendment from last year, which you also, I believe, is the same. I didn't do that bill last year, but if you would like to see it, I can pull it up for you if that's helpful.
That would be helpful. Thank you.
Okay, let's see if I can manage to pull up the right thing.
Yeah, because that does explain it, outlines it all.
Do you see that there?
Yes.
Okay, so you can see there, this is a striking out the subsection, striking out the existing subsection 1, and you can see there what Representative Craven had mentioned, I think she did A at the end, just because that's the way the revisor's office would have done it. But you can see that part about the mother in paragraph A, and then all of the other things she mentioned there are in paragraph 2, and you can see the and in between, that it has to have both of those things. Medically necessary, yeah. And then the other thing that you will there is a preliminary fiscal impact statement, and this is last year's, but that will also be included in this amendment.
And this year's is lower than last year, last
I
session.
believe that's right.
Yeah, 175-ish.
Yeah.
Okay.
So
Thank
do you
you.
want me to stop sharing that?
Any
So you can
questions
see
about
each other?
that?
Yeah.
Any questions about that? No, I don't see any questions. So yes, if you'd stop sharing, then we can all see each other. So there's a motion on the floor, ought to pass as amended. We have a better sense of the amendment. Did somebody second that?
I'll second that.
Representative Perry seconds that. Any further discussion about this? I don't see any. So at this point, we would ask Carrie to call the roll on the votes.
Representative Zager.
Yes.
Representative Zager, yes. Representative Lemlin.
Yes.
Representative Lemlin, yes. Representative Stover.
I don't see her. There she is.
I see her.
I see her. I
Representative.
think
Might be
she's
frozen.
frozen. I'll text her.
Okay. Senator Baldacci.
Yes.
Senator Baldacci, yes. Representative Perry.
Yes.
Representative Perry, yes. Representative Griffin.
Yes.
Representative Griffin, yes. Representative Connor.
Yes.
Representative Connor, yes. Representative Craven.
Yes.
Representative Craven, yes. Representative Madigan.
Yes.
Representative Madigan, yes. Representative Javner.
Yes.
Representative Javner, yes. Senator Moore.
Yes.
Senator Moore, yes. Representative Meyer.
Yes.
Representative Meyer. Senator Claxton.
Yes.
Senator Claxton, yes.
She's trying to come back in.
There's Holly.
Representative Stover.
Yes. And is my video working again? Because I've been in and out because it keeps dropping the call. I apologize.
Yes. Representative Stover, yes.
Okay,
That's-
that concludes the voting, and I appreciate it. We've been through our first work session today. That was a good surprise. Is anybody signed up for, go back to Anna. Is anybody out there who wanted to talk to us this afternoon, who wanted to go early, or anybody with a book report?
I don't have the afternoon people because they were all scheduled for 1. The book reports are up to Senator Moore and Representative Zager.
Okay.
Not up to me.
Does anybody want to do a book report?
No, I just wanted to thank my awesome committee for this wonderful vote. Thank you.
So is there any harm for taking an hour and a half break for lunch? Yes, Representative Connor.
Yes, thank you, Mr. Chairman. I just wanted to make it officially on the record that I will not be here this afternoon. I will be in another committee. So for those folks watching, I just wanted to make sure that that was annotated.
And as with Dr. Connor, Representative Connor, we've moving in and out of committee all day long. So Representative Moore.
I was just going to say, Senator Claxton, I would be happy to go ahead and do my report. It shouldn't take that long. And then perhaps Representative Zager may want to do his later on, because I think his is probably going to be longer than mine. Just a thought, or unless everybody wants to go to lunch, that's fine, whatever works.
I could do it at the pleasure of the committee. I could go now or later, whatever people want.
Well, I don't see any major objections. Nobody's shaking head that I can see. Why don't you go ahead, Senator Moore?
All right, I will do that. Thank you. The report that I'm actually going to be sharing with you is—
Sorry, I have to leave to be in another committee as well. I'll be back soon.
Okay.
All right. So the report that I accepted was the Palliative Care and Quality of Life Advisory Council Annual Report. And if you remember last week, I believe it was, Lauren McAlex and Elizabeth Keene actually presented to us on behalf of the Palliative Care and Quality of Life Advisory Council. It was established by statute back in 2015, actually. So they provide annual reports every year. It was just a one-pager, small little report there, and she did highlight quite a bit of the items that they have been doing over the past year. So I'm not going to read everything into details. I'll just kind of summarize it quickly so that you can maybe recall some of the conversations that we had with it. One of the major activities of the Advisory Council in 2020 was actually the LD 1950, which was the Act to Advance Palliative Care Utilization in the state. And it was originally, we looked at the bill, but we decided not to have to do the bill or to process the bill, and decided to send a letter to HHS. And we sent a letter to and they sent a letter to the Advisory Council, and requesting additional data and some recommendations. So Representative Zager is going to be covering the recommendations and the report back from them from that review. They did talk about their potential collaborators, the list of Maine Primary Care Associates, CDC, National Association of State Health Policy, Maine Cancer Network, the Cancer Foundation, Down East Public Health, AARP, quite a few of them that they work together. And the idea is that they were trying to look at a comprehensive palliative care services to involve a team approach so that they could come up with a collaborative issue and an effective model of reimbursement. Because right now, the only reimbursement that happens is when someone is in hospice and the palliative care is related to hospice. And that way they are reimbursed for that. However, we do know that there's palliative care for folks that are not in hospice or not in need of hospice. It's just getting that information out there. So reimbursement is a huge issue. They did talk about their Project ECHO, which is facilitated by Dr. McAlex and Deb Silverstone with support from Maine Health. It continues to generate interest, and they have a robust attendance between anywhere from 30 to 40 healthcare professionals who participate monthly. So that's really encouraging. And it gives them an opportunity to learn from one another about palliative care and how to present it, how to get it out in the public and make it known to others. So I think that's really good. And I'm sure this is one of the positive things of pandemic has resulted in the fact that they are able to do it via Zoom. And so I think you do have a lot more folks that are able to participate, where if they tried to call a meeting, it probably would not have that strong participation in it. They did mention that one of their goals is to do ongoing education for healthcare professionals, consumers, patients, and families, and it continues to be a priority. However, what they were planning to do was have a statewide palliative care conference, and of course that had to be postponed. They are looking at what might be Maine Cancer Foundation and others have expressed interest in offering financial support, and potentially they'll have it in person or a virtual conference sometime this year. So that stay tuned is one of those things with that. The Advisory Council members are oftentimes invited to share their experiences, their insights, and recommendations during the state comprehensive cancer planning process. So they felt very, very proud of that, to be asked for that. Their grant writing is an ongoing process in order to fund certain priority initiatives. One of their current priorities is to increase the accessibility of palliative care for rural Maine, which we all know that's near and dear to my heart. And the Maine Health Access Foundation has invited them to submit a full proposal for their, they're calling it the SIRG grant funding cycle. And that proposal will focus on palliative care service delivery in rural parts of our state. The deadline is in April, so they're working on that very strongly. They have some interns that have shown interest in the work of the advisory council, and so that's encouraging that they may have some individuals who will represent the future of our healthcare system, and they are welcoming them and inviting the interns to be a part of the council or to come and work with the council, the executive staff. And then finally, the advisory council members continue to monitor federal legislation that may impact both hospice and palliative care. So advocacy efforts may include calls and letters from individual members and/or a position statement from the council. So it was a busy year for them in 2020 in spite of the pandemic. And so that is their report. So thank you. You're muted, Senator Claxton.
No, I just figured that out. Thank you, Senator Moore. Are there any questions for her based on this report? All right. Representative Zager, are you prepared or do you want to go later on?
I am prepared, Mr. Chair. Thank you, Senator Moore, for that report. And indeed, I do have a few minutes to share the recommendations from the Maine Hospice Council and Lauren, Dr. Michalakis and Ms. Keene. This is in response to a request by this committee last March for them to submit this. They point out in terms of background and evidence that the studies definitely show that patients with serious illness experience pain and other symptoms, lengthy hospitalizations. These are extremely expensive, and unfortunately, a lot of times there are futile or costly treatments that are in some ways against what people would think that the loved ones would want. There's some cornerstones of a specialty. This is a multidisciplinary approach. That's one of the emphases. They do talk about describe studies. I can go into it if people would like, but essentially the use of a multidisciplinary approach for palliative care improves quality of care and decreases cost to the tune of between $7,000 or $10,000 per patient that is enrolled in palliative care as part of their care plan. Unfortunately, only about 27% or at 27% is what's quoted of Maine's hospitals provide access to inpatient palliative care. And so this is concerning. The potential explanation for that is lack of awareness on the part of providers of healthcare, lack of awareness of palliative care on the part of patients, families, and consumers of healthcare, lack of workforce capacity in palliative care, and a lack of reliable and sustainable reimbursement models. They emphasize this team-based approach, which includes physician, advanced practice practitioners, nurses, social workers, pharmacists, therapists, and chaplains, among others. The goal is to identify patients and engage them upstream, again, to improve outcomes and lower costs. One study, in addition to the money saved, as I said, it was, one study showed $7,000, others show up to $12,000 saved. Outpatient palliative care, so this has reduced hospital admissions by about a third. So 34% fewer admissions, and that's largely considered one of the drivers of the cost savings. And of course, meeting more more consistent with patients' wishes. There are other states, California, Arizona, Colorado, and others have established Medicaid palliative care benefit. And they point out the value or the deficiencies of a fee-for-service model, and instead talk about a value-based model, such as a per member per month palliative care benefit. And this is indeed supported by the research by and the policy statements of the National Academy of State Health Policy, NASHP. I'll skip a little bit more of the evidence and what California has found, unless people want me to go back to and skip to the summary and recommendations. So number one would be to endorse and adopt the definition of palliative care, recognizing the value and contributions of multiple state, members of a multidisciplinary team. Number two would be to endorse and adopt broad educational initiatives, informing and empowering the patients, families, and consumers of the availability of it. Endorse and adopt educational initiatives to expand the workforce. Number four is to explore options regarding high quality and patient-centered interdisciplinary care. Number five is consider the integration of palliative care into other value-based initiatives, such as ACOs, patient-centered medical homes, etc. Number six, consider organizing a 3-year pilot to explore community-based palliative care models. Number seven is funding and support for the work of palliative care of this advisory council, the Palliative Care and Quality of Life Interdisciplinary Advisory Council, to organize all these above. With that, I'll just comment that this is a very good example of an intervention, of a systems change, an intervention that it would both improve outcomes and reduce costs, both of which would be huge wins. With that, I'll stop and see if anybody has any questions.
Does anybody have any questions for Representative Zager? I have one. Based on what you just heard in that, or just presented, or what you read in the report and then presented, is there any opportunity in there for the introduction of legislation that you think that might help move things along? Because that's one of our options as the committee record. Based on our reports, we can come up with a committee bill that would pursue any of the recommendations or any of the thoughts that come out of any of the reports that we see. So is there anything based on your reading that should be considered for legislation?
It's funny you ask that. Yes, I actually was, as I was reading this, I was considering a bill that I had, you and I have talked about previously. And one thing might be to, it's not printed yet, but to incentivize payers to view palliative care as a valuable upstream intervention, to require them to invest more in it as a percentage of the overall amount that is spent in the state on healthcare, so that we could hopefully achieve better outcomes, fewer hospitalizations, lower costs, better outcome, better care. And I think a resolve for a study on this might elucidate opportunities more. Although I think the evidence is rather compelling, and NASHP and other entities have published reports, and so I'm not sure that that there needs to be a lot more study. Although the Maine Hospice Council may wish to find out more, or that might yield information that would be a better yield to a better systems change.
So has anybody got any other thoughts about how we might move the needle on palliative care, accepting that it's beneficial in many ways? Any thoughts? Yes, Representative Javner.
Thank you, Senator Claxton. Representative Zager, I'm curious then, you mentioned a bill already that you have submitted. Is what the information in this report going forward, is it in any way that we would simply take your piece of legislation and turn it into a committee bill, or is it completely separate? What would you recommend?
Well, thank you, Representative Javner. The bill that I had is not was not originally conceived of as a palliative care bill. However, the purpose was to enhance investment in primary care and behavioral health, mental health care. Both of which I think in philosophically have a lot to do with palliative care. And even though it's not always office-based, it is very much it's a community-based part of healthcare, and it would empower patients and improve health outcomes as these studies have demonstrated, and lower costs. So it's.
And I apologize for interrupting. However, could you please just give a very concise, very wow us, if you could, with your definition of what palliative care is?
Well, my definition of palliative care is I would say that palliative care is the treating of the emotional, integrating the physical, emotional, care for the physical and emotional needs of a person who is facing serious, usually life-threatening illness, to meet their overall care needs.
Does that answer your question, Representative Javner? So a couple of examples. Obviously, there's a bit of palliation that goes into somebody who's in hospice who has pain. You're getting pain medicines. You're likely getting something for anxiety because the pain makes you anxious. That would be considered part of palliative care. But if you were diagnosed with an advanced lung disease and you could anticipate being able to survive another several years using oxygen, doing some palliation of the anxiety that goes with being hungry for air all the time would be considered palliative care and have nothing to do with a known expected hospice-defined 6-month window for end of life. So palliative care can occur anywhere during the spectrum of life, but is usually, as Representative Zager mentioned, usually as somebody who has a defined life expectancy. Although my wife, who's a hospice chaplain, took care of somebody whose anticipated death in 6 months took 16 months from his COPD. So no crystal ball comes with it, but it's an attempt to address the issues that lower the person's quality of life, improve their quality of life for whatever remaining time they have.
Thank you. Thank you, Representative Zager, and thank you, Senator Claxton. So as a committee, as we look forward to, perhaps a piece of legislation, what I'm hearing is that it would be a separate piece of legislation than what Rep. Zager has already introduced. So obviously that's the conversation that needs to happen. Thank you.
Yes, and I think that's a good step forward. Yes, Anna Broom.
I just wanted to point out, if you want to see it, that there is a definition of palliative care in statute.
Okay.
And also that if you wanted to, because we didn't have an opportunity to do this ahead of time, we could bring in the authors of this particular report and you could have another work session on it if you wanted to explore what is necessary to happen in statute. I do think that things like per member per month, that's not currently how I mean, this bill came out of, this letter came out of a bill that was establishing a palliative care benefit, which some people believe is not covered under Medicaid. The department said that they have a hospice benefit. So that was the whole conversation that happened last year. But if you wanted to, we could invite those folks to come back again. They were available last time, but you ran out of time to do it. If you remember, they had presented as part of the statutory bodies, and it went long, so there wasn't time for Representative Zager to do his report. So they were ready then. And in the meantime, we could see what is necessary if you want statutory changes, what you actually need, because I'm going to assume that some of the recommendations will require some statute and some of them won't. And I certainly don't know off the top of my head what those are, and Representative Zager will know the medical side of it, but not the statutory side of it. So if you wanted us to do that, that would be one option. I also just want to mention that this report technically came from a letter, which doesn't give you authority to report out a bill.
Oh.
However, in this particular case, it's technically part of the report that Senator Moore had. So you actually could do it pursuant to the that authority that's involved in statute for the Hospice Council. So in this particular case, you get slightly lucky.
Another piece of evidence of why we're so lucky to have our crew with us.
Well, and you did actually write this letter specifically last year to say, when you do your annual report, do this too.
Okay.
So I think you've covered your base there.
All right. So how does that sound to folks? Invite some people back from palliative care and hospice to hear about their thoughts about what would have to move this report from a report to any legislation that would be worth pursuing. What do you think about that, Senator Moore, since you gave the report?
Well, I think that's a good idea, because some of the recommendations, like one of them was to consider organizing a 3-year pilot. So that would be maybe something. It also talked about funding and supporting the advisory council to organize, oversee, and support. So that would be a good questions that we would be able to ask them as to what does that mean? What would be required? And then considering, including it in other value-based initiatives and care structures as appropriate. So I think there are some areas there that could possibly be in need of legislation. And I think that's a great idea to ask them to come back and help us understand and put our hands around what the recommendations are saying.
So maybe they could come back with their list of priorities.
Yeah.
And we could consider that in the order in which they've raised them as priorities, and have them do some pre-work before they come back to us.
That's a good idea. That's a great idea.
I see some head nodding. Are folks generally okay with this approach to inviting them back and trying to see if we can move the needle on this? I see lots of nodding heads. So thank you to Senator Moore and Representative Zager for moving the needle in the committee. And we now have a couple of next steps, and Anna will help coordinate that. So thank you all for that. That's a nice outcome of reports. We didn't see a lot of that last session, but this is good. Any other questions or concerns that come before the committee? Yes, Senator Moore.
Yes, I just wanted to share with the committee. I had a message from Carrie Bickford, and she's apologizing for her technical issues. She said her computer froze up, and as she was trying to get into Zoom, and then YouTube wouldn't shut off. So she apologized for that, and she will submit her written testimony.
Okay. Yeah, that's happened a couple times that somebody had all that echo in the background. Yeah. Modern technology. Yes, Representative Zager.
Mr. Chair, thank you. I'm just wondering if, is there a simple backup plan? Like if that were to happen again, is there like a quick action, like call this telephone number and we could just do it, get it, phone testimony?
Sounds like a good question for our clerk to do some homework on that. I know there are 800 numbers that are out there. So maybe that's an option and we should keep those handy. but we'll defer to Carrie to look into that, and she'll give us a long report when we reconvene, or when she's ready. All right, any other points? Good session, folks. Thank you. I'll entertain a motion to adjourn until 1 o'clock.
I make the motion.
Thank you, Representative Wendland.
Second.
Seconds all around. All those in favor, show of physical hands will do. Senator Moore is waving goodbye. Thank you all, and we'll see you at 1. Thank you, Carrie, for doing a little homework.
Representative Craven, are you here?
I don't see her, Carrie. Should I call her?
Her bill is being heard in HCIFS at 12:15.
Okay, I'll give her a call.
Okay, thank you.
Representative Craven? Margaret? Margaret? She's just dropped off again. I can't seem to get her by phone.
Margaret, you're not muted.
Device, I'm learning how to mute it.
You reach over to the wall and pull on the black plug.
Am I muted now?
No. On the other software, I have the option to help you with that, but I don't on this one.
I can do it if you'd like, Representative Craven.
Yeah, thank you.
This morning, I could see all of you. I could hear all of you, but you couldn't see or hear me. And it showed that I was unmuted and you still, I don't know what happened. It was sort of a poltergeist.
Let's hope it was that only.
It was suddenly like, I suddenly would be disconnected. Several times I was disconnected, just.
Well, and you looked frozen to us. I mean, you hadn't moved. You were just right there frozen. It was weird.
Wow. Well, you guys
All
were
right.
free.
1, 2, 3, 4.
You guys froze up too several times, so it was very weird.
So it's now it's 1 o'clock. We can get started for the afternoon session of the Committee on Health and Human Services. We have a number of statutory agencies that will be joining us to let us know a bit about them. We've allotted 10 minutes or so for them to present and 10 minutes for us to ask questions, since these are prominent agencies in our work. So unless I hear from Anna on Aaron, I would go to recognize Thomas Newman first as being here from the council for the Center for Independent Living. Welcome, Mr. Newman.
Well, thank you. Thank you, Senator Claxton. And hello to all. I so wish we could be together in person. I am warmed to see some familiar faces, Representative Stover, who worked so tirelessly on the Direct Workforce Commission, and Senator Moore. But for so many of you, I wish we were going to meet today. I have submitted an outline to Anna, admittedly somewhat late, but that'll be posted afterwards. It's 3 pages long and it goes into some great detail, but more detail than I think we want here. So what I thought I would do to try to introduce, especially to those of you who are unfamiliar, is how do we start? What's this all about? So in the 1970s, early 1970s, Stephen Tremblay was an 18-year-old graduate from Waterville High School and headed off to college, the Worcester Polytechnic Institute, where he hoped to become an engineer. And like most young people, he left Waterville with such hope and promise and optimism. But that his life changed when he sustained an injury falling off the back of the bleachers and sustained a spinal cord injury. And he was returned back to his family's home in Waterville. Well, in the mid-1970s, when Steve finally came out of rehab, there was really no way that he could live independently to stay at home or in the community. And his family thought he would have to be institutionalized. So whether it's nursing home or other residential care facility, that's what they thought would have to happen. But happily for Steve, and now happily for all Maine citizens, that wasn't going to happen in Steve's view. And it turned out that just about that time, the independent living movement was capturing the country. And in 1978, they issued 11 grants to found a Center for Independent Living, just 11. And Alpha One, founded by Stephen Tremblay, was one of those 11 in 1978. Today, there are 433 centers for independent living throughout the country. Massachusetts, for example, has 11. Maybe it's 10 now, but we have one in Maine given our population. And Stephen Tremblay, we can thank for that founding. So what does a Center for Independent Living do? Well, first, it's not actually a center you go to. It's not a place to go to. It provides services and programs for people with disabilities. So one of the things you'll see in our outline is that the Center for Independent Living is governed and managed and staffed by a majority of people with disabilities. What does that mean? Well, in Alpha One's case, 80% of the board are people with a significant physical disability. 58% of the staff, including senior management in Alpha One, has some type of disability, whether a physical, cognitive, developmental, or otherwise. And the philosophy is that people with disabilities will have the best perspective for how to develop the programs to maintain independent living. And so that's actually required for a Center for Independent Living. And we've gone well beyond that and do many, many programs which are not administered through our SIL grant, but that's principle. So I think, well, what do you guys do, Tom? What do you do? So to save you from looking at our website and going through all the programs, maybe a hypothetical of one of our own employees would be helpful. And I think that 2 years ago when we did this, folks found it helpful. So one of our employees, Jessica, was a fabulous soccer player at one of the smaller high schools north of Augusta. And she went off to the Rochester Institute of Technology as a recruited soccer player. But coming back from one of their road trips, they incurred a center head-on collision, and she sustained spinal cord injury and came home. And coming home at age 20, she was thinking, wow, last place I want to do is, I was just getting independence from my parents, independence from my family, just about to launch my independence, and now, I'm rendered incapable of doing just about anything. So what do I do? Where do I go? So the first step is, if you call Alpha One, information and referral is one of the first services provided. Information and referral. Representative Stover is going to shake her head. She must have heard us talk about this a million times, as do the AAAs. There is no wrong door. You make a call to any one of us in the network, we'll get you to the right place. There is no wrong door. And where you have to go is the assessing agency, the ASA, Assessing Services Agency, to get an assessment. You've already had a medical assessment by the providers who are basically dealing with you right after the injury. But you need a functional assessment to see what are the activities of daily living that you can no longer do yourself as a result of the spinal cord injury. And with that assessment, you then qualify for all kinds of programs for support and help. Well, you'd have to get referred by the assessor to, then you can make a choice. You can choice of 2 service coordination agencies. Alpha One is one of them. Seniors Plus is the other. And we work together all the time. Once here, our care coordinators will go through your personalized plan of care and look for all the things you need. There could be any number of things. Could be, wait a minute, they missed the home modifications you need for access to your home, for ramps, for facilities to facilitate use of the shower or the bathroom facilities, etc. But even with all those home modifications or assistive technology, you're not going to be able to get through basic daily activities like transferring from your wheelchair to the shower or chair to facilities. So you may need a personal care attendant, personal attendant. 2 ways to get it. One is through the agency services, but one is to direct your own care. And the model or philosophy is not that you're a patient that someone will take care of, but rather that you are a consumer of services. You can direct your own care. And in these self-direction programs, the consumer takes charge. The consumer is in control. So, well, that's terrific. How do I learn to become my own employer? We provide the skills training. Skills training is the specific HHS service through the main care programs. And the skills training gets provided by, at Alpha One, independent living specialists who've been working on this for many years. Once they learn that, then the individual disabled person can hire their own attendants, and they have to certify the competency. Well, who better than the individual, him or herself, to say whether this attendant is competent to serve as a personal care attendant, rather than having some foreign agency do the scheduling and making that determination. Once they do, they may say, well, wait a minute, Tom, that sounds terrific, but I don't know anything about payroll taxes. How am I going to do the withholding and the payroll and the quarterly 941s, et cetera? And it even seems more complex with this because it's not even a basic 941. You got to have the Schedule R. Don't worry. To do self-direction programs, you are required to choose a fiscal intermediary. And there are 4 in most programs, well, 3 in nearly all programs, 4 in some. And always 2 of the local state folks, Seniors Plus and Alpha One, both have related entities or partners who can provide those fiscal intermediary services. And those are also governed by the same set of main care rules to address what has to be done. But that's just one of many. You say, terrific, I want to work. I want to stay in the community. How can I get transportation? I mean, how can I have a vehicle? I don't have legs anymore that work. I can have arms. We have started way back in the 80s, back when Stephen Tremblay first was getting this rolling, started an adaptive driver evaluation and driver education program. So the number of 16-year-olds who come through, in fact, I've taken the training myself just to see how it's done. And I'll tell you, it's scary to get on. I never got on 295 with that adaptive vehicle. I did make it through the cemetery in South Portland. That was very safe. Got a little scary when I went out on the main roads because, not using your feet, just your hands. So it takes some training, but I wanted to see how it's done. I'm very proud of our group. We continued that through COVID, although we had to take a respite during the winter months because we can't get a safe environment. But come mid-March, we'll be back on it with windows open, masks on, and those teenagers coming right back in to get their driver's license in an adapted vehicle where it's arms only. So that's one of the many transportation issues. But where I first got involved, I was just outside counsel to Alpha One in the 80s, quite a young lawyer. And I remember Steve Tremblay calling, hey, Tom, we got this little driver eval where we have people with disabilities going out on the highway. Do you think we need liability insurance? Let me think, Steve. So there was, at that time, very basic needs. So I pro bono services were focused primarily on just some obvious things. But that's one of the many programs we do. We have peer groups, peer support groups, advocacy groups. We used to be chasing down folks about barriers to entry, but we've turned that work over to our good friends at Disability Rights Center, now Disability Rights Maine. And we have an architect on board who will help you find solutions. We're really focused now on finding solutions, not finding fault. And in fact, we added the tagline to our name, Alpha One, Disability and Aging Solutions. So where you focus, you can find a solution. And that's the primary focus of Alpha One today.
So you've used it sounds to me like you've used the term Alpha One and the Center for Independent Living pretty much interchangeably, but I don't think that's the case. Is that right?
That is correct, Senator. Alpha One is the only Center for Independent Living in Maine, but the federal government has chartered 433 centers for independent living. And it's largely based upon population and needs.
Okay.
The SILC, the Statewide Independent Living Council that you heard from Beth Mogan earlier. Beth, by the way, former employee of Alpha One, and someone that we work closely with all the time. As the SIL, we have a seat on that council. And every 3 years, we have to do a state plan for independent living, and that addresses our needs and can make a pitch for additional funding if we think we could use another. There was a time when there were 2 SILs. There was one in mid-state, but they only did the Title VII-B funding, and they couldn't manage it. So they asked Alpha One to take that over too. We've always done the Title VII Part C SIL work, and they asked us to take that on too. So since that time, which was I think early 1990s, we've done all of the SIL work. So okay. Yeah, so it's not, and Alpha One does programs that are not chartered or funded by the SIL as well. So you're absolutely right, Senator.
Okay, thank you. Senator Moore.
Yes, thank you very much, Tom, for that presentation. I discovered Alpha One when I was a cancer patient navigator, and I had not ever heard of it, and it's been very priceless. Now, am I correct in understanding in the consumer directed services, they can actually even hire a family member to take care of them? Is that correct?
They can hire a family member, but in the main care programs, they currently cannot hire a spouse.
Okay, gotcha.
Whereas in the state-funded home-based care, state-funded consumer-directed home-based care, a consumer can hire his or her own spouse, not in the main care programs. It's because the current interpretation of CMS rules. Now, you may recall that folks went to the legislature a while back and did get that changed for agency services there, but technically there, the employer is the agency, not the spouse. And so that doesn't really make a lot of sense. And so I've talked to Brenda Gallant, and we're thinking of trying to go back and address that again.
I think it would be worth doing that because I think that's important for that. You also mentioned just one more question. You said senior care or something. You said it was Alpha One, and what was the other organization?
The other organization I was referring to, Senator, is Seniors Plus.
Seniors Plus, okay.
Yeah, and Seniors Plus and Alpha One are the two agencies that provide service care coordination in Maine.
Are there other questions? 2 years ago, we sat and had a chance to hear from various folks about what they did. There were so many people doing so much work, it was hard for me to know if people were bumping into each other to get the work done, or if they had managed to divide up the work in such a way that it was effective. And having referred to Alpha One a number of times in my career, it was good to begin to understand that, yes, some people do similar things, but we don't overlap and waste any resources. So how do you coordinate with the other people that you work with or direct folks to join in the effort for an individual?
Well, it probably depends, Senator, on which partner. But when it comes to meeting consumer needs, we have to work with all of the home care staffing agencies, of which there are dozens, and we provide services statewide. So one of the things we've done to have things be streamlined and coordinated, particularly in the state-funded program, we joined with Seniors Plus to meet with them, and we now have regular sessions with the Home Care Alliance to address how we can have uniform systems so that the home care staffing agencies don't have to have one set of contracts and procedures with Seniors Plus and a different one with Alpha One. We agreed to do them the same. There's even more coordination efforts underfoot as we speak, because Michelle Probert, the head of OMS, identified this issue of the dual eligibles, people who are eligible for both Medicaid and Medicare. And we are now undergoing coordination efforts with 5 DSNPs, so-called dual eligible special needs plans of the insurance companies that serve dual eligibles in Maine. And we're working out coordination systems so that we don't overlap, but also so we don't miss consumer care that this Medicaid main care member could be getting from Medicare under their contract that they don't know about. So we're working on that. Exploring whether to join the Health Info Net, which is a secure way to get additional personal health information without it flying around in unprotected fashion. So just two examples there.
We'll be hearing from them shortly. Are there other questions for Mr. Newman? Yeah, that was one of the high points for me last session, was to find out how much incredible work was going on in various places that you might not otherwise hear about unless you were somebody who needed those services. So thank you for your work over a lot of years.
Many years. And, it's only on these Zoom calls that, you look younger than you really are. So I've actually started working with Alpha One my 3rd week of law practice in September 1980. I got this random phone call from a sister, one of my friends from high school, Cardinal Mooney High School in Rochester, New York, said, "Hey, Tom, I'm working for this nonprofit over here in South Portland. They just got started and they need a lawyer. It needs to be cheap. So I thought of you." So I've been out of law. I was out of law school and my federal clerkship for 1 year and there I was 3 weeks into practice. So I went and met with Steve Tremblay at the John Martin's Mary Manor in South Portland, and the history is from there. So I many years of immersed in the mission of Alpha One. So when it looked time for chapter 2 of my career, I welcome the board's request to step in and help out.
Great, great. Well, I don't see any other questions, but we are grateful that you're here and helping us understand the complexities of these interrelationships. So I appreciate that a lot. Thank you.
Thank you for the time today. And I will throw open to the entire committee that should anyone have any question or issue of any nature, anytime, shoot me an email and I promise I'll respond.
And there is a PDF that he has forwarded for us to review that's arrived this afternoon. Thank you again.
Which hopefully is able to manage and probably not as interesting as our exchange today. So I appreciate your time.
Thank you. So next we're joined by the folks from the Center for Inclusion and Disability Studies. That would be Alan Cobo-Lewis. Welcome, sir.
Thank you very much, Mr. Chairman. I sent, hang on just a moment. Sorry, I couldn't talk and manipulate Zoom at the same time. I sent this file ahead to either the analyst or the clerk, so I hope you can see it.
We got it too.
Great. Okay. Right, I'm Alan Cobo-Lewis. I'm the parent of 2 adult children, one of whom has autism, and director of the UMaine Center for Community Inclusion and Disability Studies and associate professor of psychology at UMaine. There's our website, which I will not go through. I'll follow Mr. Newman's example and just give you a few examples of the kind of activities that CCIDS does. This is a diagram of Maine's Developmental Disabilities Network. These 4 entities, one of whom you're going to be hearing from later today on the Maine Developmental Disabilities Council, I think at 2:40. These 4 entities exist in every state under the Federal Developmental Disabilities and Developmental Disabilities Assistance and Bill of Rights Act of 2000. The 4 entities are CCIDS, just as Alpha One is the Center for Independent Living in Maine. CCIDS is the University Center for Excellence in Developmental Disabilities in Maine. There's at least one UCED in every state. There's 67 of them overall, because big states have more than one. Every state has at least one, and we are the one in Maine. The other entities created by the DD Act are the Maine DD Council, who you'll be hearing from shortly, Disability Rights Maine, which Mr. Newman mentioned, who I think you may have already heard about, because I think their day wasn't snowed out. And speaking up for us is the self-advocacy organization run by people with developmental disabilities. Developmental disability in this context means essentially a really significant disability with onset before adulthood. It frequently includes, but does not always include, intellectual disability. This University Center for Excellence in Developmental Disabilities, we pronounce that acronym UCED, UCEDD. So you'll hear me say UCED a few times this presentation. UCEDs have 4 core functions, which almost parallel the tripartite mission of UMaine as a land-grant institution. So they are research, education, and service. That's the 3 functions of UMaine, plus dissemination, specifically in developmental disabilities. So research is defined under the Act to include basic and applied research, and also to include evaluation and policy analysis. Education includes pre-service prep and continuing education, and service includes training and technical assistance. So you'll find our UCED does not do the kind of direct service that you heard from Alpha One. We do sometimes do model programs or demonstration programs. And of course, dissemination to disseminate information about the state of the art and best practice in developmental disabilities. So we're created by the DD Act. The purpose of the DD Act is to assure that people with developmental disabilities and their families participate in the design of and have access to needed community services, individualized supports, and other forms of assistance that promote self-determination, independence, productivity, and integration and inclusion in all facets of community life. Very similar values to what you heard from Mr. Newman's presentation. Through culturally competent programs is also in the statute. Part of the USAID federal mandate is to educate and advise policymakers, including members of the state legislature, and that's why you're hearing from me today. The history of the DD Act goes back to the Kennedy administration. So this is the Kennedys in the 1930s, when there was when we had a president who had not a developmental disability but a disability. JFK's sister Rosemary had a developmental disability from birth, and really she was the inspiration for the creation of the DD Act. I said DD Act of 2000. Its predecessor goes back to the 60s. Its creation was essentially one of the last things that President Kennedy did before he was assassinated. By statute, we are guided by a community advisory committee, which is comprised of lots of stakeholders from state agencies and community agencies, and importantly, people with developmental disabilities and family members of people with developmental disabilities. So example activities of what we do at CCIDS. One of them is actually a joint project with the University of New Hampshire Institute on Disability and Dartmouth Hitchcock Medical Center. This is called New Hampshire Maine LEND, Leadership, Education, in Neurodevelopmental and Related Disabilities. This is a training grant. We have a couple dozen trainees per year who are cross-discipline. They're frequently graduate students in social work, communication science and disorders, occupational physical therapy. We also have family members of people with disabilities and people with disabilities in the training program. It's a 300-hour program that progresses over a year, and that includes there's a clinical component, there's a leadership component, and there's a seminar where they learn about history, and essentially they learn about family-centered intervention and advocacy in the field of developmental disabilities. Another example of a project going on at CCIDS is Project Scope, supporting children of the opioid epidemic. So this is actually funded through the LEND program that I mentioned previously. So we're doing this with UNH and actually also with University of Wyoming, which is building nationwide provider capacity and applying evidence-based practices in screening, monitoring, and supporting children diagnosed with neonatal abstinence syndrome, neonatal opioid withdrawal syndrome, or suspected of being impacted by opioid use, trauma, or related exposure. Project Scope uses a telepractice model whose importance has become very obvious during the pandemic. It's called ECHO. It comes out of the University of New Mexico Medical School. So it was really targeting rural areas that didn't have easy access to tertiary quaternary care centers. So it educates primary caregivers on evidence-based best practice. And you'll hear me talk more about evidence-based best practice because that really drives our activity at CCIDS. Other examples of other activities from CCIDS personnel includes the AFARI. So this was developed by a couple of faculty who have joint appointments in CCIDS and other units in the university, specifically for people with physical limitations. So I think of it as a walker on steroids, although you see it's much more than a walker. This has wheels that are almost bicycle size. This is really a jogger more than a walker. And you can get out and it has wheels that you can work in various different terrains. And it facilitates inclusion in the community in a very real way. This is a picture of the AFARI at the track at UMaine. This is a picture of the AFARI in the Cooper Hewitt Smithsonian Design Museum's exhibit called Access and Ability, about adaptive equipment that's non-stigmatizing, that's aesthetically pleasing, and that's beautiful, which also facilitates real community inclusion. And at least before the pandemic, it was part of the world tour of that exhibit. We have a number of other activities. I'm not going to go through them all, but they include an undergraduate minor in disability studies as part of our education mission. We are one of the largest minors at UMaine. It includes a graduate certificate in disability studies. We do research, evaluation, and technical assistance on childcare and education of children with disabilities at the other end of the lifespan. A lot of this work is really targeting giving support to childcare providers so that children with significant behavioral challenges don't get suspended or expelled from early care and education, which there's research indicating that actually happens nationwide at a rate higher than it happens in K-12 education. We are conducting research on reducing the use of restraint and seclusion on children with disabilities. Research and evaluation on wait lists for home and community-based services. This is a very significant issue in Maine. We've done for the past few years a pilot with partners at the university and at the state on preparation of high school students with autism for post-secondary education. That's something we actually started before the pandemic and managed to run it last summer during the pandemic as well, where they take a 4-credit course and also learn about how to engage in self-determination, directing their own education, directing their own lives, and a number of other activities. Some activities that we're doing during COVID include a social and distancing project where, so this was in some partnership with the Maine Developmental Disabilities Council. The Maine DD Council had a program where they distributed iPads to people with developmental disabilities who didn't have access to technology, which left them even more isolated than they previously were. And so our component of this was to actually provide support for them to organize activities using that technology to connect with people when they had to socially distance. Other COVID-related activities included research and evaluation about disparities in COVID impact. I think you're probably familiar with the fact that people in congregate care, which included more than people in just nursing homes, were really significantly impacted by COVID at rates higher than the general population. And also activities on equitable access to treatment and vaccines, treatment and vaccine and access to supports. So this goes back to the early days of the pandemic when in March of 2020, the Office of Civil Rights in the US Department of Health and Human Services issued some bulletins, essentially making sure to make sure that people with disabilities were not triaged out, and access to ventilators was the first issue. It also becomes access to vaccine, and the issue also comes up in addition providing support to those folks because sometimes they do get hospitalized, and because of visitation policies, which are understandably very restrictive, some folks around the country have been denied access to people that they need to help them communicate with hospital staff, which interferes with a direction of their own care. And so we've been doing some dissemination activities on making sure that people are aware of these bulletins. CCIDS is an interdisciplinary research unit at UMaine. As such, we are committed to solutions that are grounded in science and driven by data with a goal of inclusion of people with disabilities. With that background in mind, we may testify on key bills with particular importance to people with disabilities and their families. It is always with an eye to where the evidence points. Consistent with UMaine Board of Trustees policies, CCIDS personnel may testify in our capacities as professionals, scientists, or faculty, and we may represent the center as authorized by the DD Act and Board of Trustees policy, but we will not speak for the campus, the university, or the university system as a whole. And lastly, CCIDS has a relationship with the UMaine Institute of Medicine, which is a new initiative of UMaine. The mission of the Institute of Medicine is to develop through innovative and coordinated research, education, and strategic partnerships, transformative solutions that enhance the health and well-being of the citizens of Maine and beyond. So this connects on basic research and applied research with community resources. And of course, CCIDS does basic and applied research, but more applied than basic. And services tend to be very community focused at CCIDS as well. And I'm happy to answer any questions that any of you might have.
Thank you for that. Do I see any questions from the committee? Can you give me some idea of the number of lives that you touch primarily or secondarily in a given year?
I should have actually done that. I should have checked that before this presentation, shouldn't I? I mean, certainly thousands.
Okay.
You know, the direct service that we do is limited because we tend to do demonstrations or research and evaluation. And so in terms of that, you know, we have thousands upon thousands of people downloading materials that we produce. Most of our work tends to be research and policy oriented. So we have an impact on thousands of people across the state, but it tends to be indirect, you know, through essentially development of better evidence-based programming.
Okay. And if somebody from your effort, you said, comes up with a brilliant idea for legislation or wakes up one morning and say, wouldn't it be great if, how do you get that idea to the legislature? What's the next step for you all?
So the DD network, the four entities that I mentioned, I think the second slide, we confer about policy directions, live issues statewide all the time, and we tend to coordinate our efforts. And so really, it's the DD network as a group that may be reaching out to or responding to legislators, or more often simply reacting to bills that have been introduced. Bills in the Education Committee, we frequently confer about concerns or excitement that we might have about special education regulations. In this committee, if things come up about home and community-based services, frequently one or more of those four entities, will weigh in about either concerns of the members or what the data show about how we're doing on wait lists, or what best practices to facilitate real community inclusion and getting people to actually have meaningful work, for example.
Mm-hmm. Those are the questions I had. I see one from Representative Meyer.
Thank you, Mr. Chair. Thank you, Mr. Cobo-Lewis. I just wanted to extend my thanks to you on behalf of this committee for the work you've done and presented to us in testimony on wait lists here in Maine. It's been invaluable, and I assume perhaps we'll see you next week in front of AFA.
I think that you will see me in front of AFA next week. At this point, it may be in my personal capacity, but you'll definitely see me. This committee's definitely heard from CCIDS about waitlists in the past. And actually, when I mentioned restraint and seclusion a few years ago, I think you heard from us about better data collection on restraint and seclusion in psychiatric units for adolescents. I think Representative Siraki was very active on that issue. I'm going to work with us on that as well. You can see pretty wide-ranging, focus on community inclusion, meaningful work, meaningful self-direction of lives of people with disabilities, of people with developmental disabilities. Thank you for saying that, Madam Chair.
Thank you for being here and for answering some questions. I'm sure others will come up, but we'll have a chance to see you down the road.
Thank you. And thanks for this opportunity.
So next we're joined by Sean Alfreds. Welcome, Mr. Alfreds.
Thank you, Senator Claxton, Representative Meyer, and the Committee on Health and Human Services. I appreciate the opportunity for being here today. I believe I sent out materials earlier this morning, but if you don't mind, I'll share my screen if we can get the technology working. As a gentleman who works in technology every day, I always squinch when I have to give a demonstration or use technology because that's when it breaks. But I'm going to pull up my screen right now. Hopefully you all can see it.
There we go.
Excellent. Okay. So today
Can you switch to presentation mode if you're going to get into the weeds and some of the smaller slides?
Absolutely. Escape out of this.
Thank you.
Can you see that now?
Not yet. Yeah, there we go.
Excellent. Okay. So I appreciate the opportunity to present to the committee today. As many have said previously, I wish we could be in person, but it's nice to see you all, and I'm glad we have this technology in Zoom to see each other and to talk about these important issues. What I'd like to do today is give you an update on Health InfoNet, our work across the state, and then open it up for questions so that you can inquire about some of that work and how it's impacting the citizens of the great state of Maine. Health InfoNet is a nonprofit 501c3 organization that's designated in state law as the operator of Maine's Health Information Exchange. There are a number of state laws that represent and or reference Health InfoNet. And govern consent requirements for patients' participation in the Health Information Exchange, which I will discuss with you in a moment. Our organization is an independent organization. We have a board of directors that represents our community of providers, public health agencies, patients, government agencies, and statewide businesses. And we provide our role is to provide a number of services with the primary mission of improving healthcare outcomes and improving population and public health. Going to the next slide. There we go. Health information exchanges. This is a term that gets used, but it's very poorly defined in my experience in the industry. But in general, health information exchanges like Health InfoNet are systems that combine information from multiple healthcare services organizations, electronic medical record systems, electronic laboratory systems, with the purpose of creating a comprehensive single electronic health record for patients that can be then accessed by clinicians at the point of care to inform decision-making, to assist in care coordination across multiple services, to improve patient safety, and as we've seen and as I'll talk to you about, improving population and public health because of the aggregation of all that information. Health InfoNet, we've been operating in the state of Maine since 2008. Our company was founded in 2006. And as of today, we're connected to over 820 locations across the state. Over 85% of ambulatory or outpatient healthcare facilities and all of the state's federally qualified health centers are connected to Health InfoNet. We get data from MaineCare, the state's Medicaid program, as well as pharmacy data from SureScripts, which is a nationwide pharmacy benefits manager. We get data from the statewide emergency medical services organization. All healthcare systems and acute care hospitals and critical access hospitals participate in Health InfoNet. A number of the state laboratories, including Nordex, Quest, ALI, Doll Chase, and the state's Health and Environmental Testing Laboratory are sending data to Health InfoNet. And some behavioral health and post-acute care facilities are also sending data to Health InfoNet. And those numbers are growing. And I'll talk about some of our programs in those areas in a moment. Who are our users? Our users are people who need access and who are authorized to have access to protected health information. These include registered nurses, medical assistants, medical record specialists, physicians, behavioral health clinicians, pharmacists, care managers, and even epidemiologists at Maine CDC and infection prevention staff. Some of our numbers to give you a sense of what data is in Health InfoNet. In today, at a glance, we have 1.7 million people's data inside of Health InfoNet's data systems. This includes lives from Maine residents, as well as people who have had healthcare activities outside, that reside outside of the state, but have had healthcare activities in the state. We have an opt-out rate, which I'll talk about, but patients have the right to not participate in Health InfoNet and not have their data shared by Health InfoNet or stored by Health InfoNet. And our opt-out rate is 1.4%, and that's been pretty consistent in my history in Health InfoNet, which has been going all the way back to its founding. We have 24,684 people who have opted in to share their mental health data with Health InfoNet. We have a separate opt-in for sharing data with Health InfoNet for special conditions, sensitive conditions like mental health and HIV. And we calculate what we call a crossover rate. This is really important and helps us explain the value of the health information exchange to folks who haven't encountered us before. And what that is in our data, the percentage of patients that we have data on from corporately unaligned facilities that are having treatment within a 12-month period. And on average, across all those 820 organizations, 61% of patients have data from more than one facility that without Health InfoNet would have to be sharing records either via fax or paper. We calculate our statistics on an annual basis, but we also calculate monthly so we can see trends in what's happening. And so what you see on the right-hand side here are our statistics and comparative statistics from last year to this year. Per month, we have over 151,000 patients that have been accessed in December, which is up from 124,000 patients last year. We have over 6,300 users. These are active users, people logging in from their electronic medical record systems to look up patients inside of Health InfoNet. Our public health reporting, we do a number of public health reporting functions, and I'll talk about those in a moment, but that's also gone up by 20% this year. As you can imagine, COVID-19 has had a significant impact on our organization. And then we also provide real-time notifications for caregivers that can associate themselves directly with a patient and receive a notification for when their patients have an event of care or even have a COVID-19 positive test result. And we can send them a real-time email notification for those events. Our services in general, we incorporate data from a number of sources. Healthcare data is very complex, and while there are lots of standards in healthcare, those many standards make it very challenging for healthcare exchange like us, because different organizations use different standards and different categories of data. So we spend a lot of our time standardizing data within the organization and organizing data around the patient. And we use some pretty complex IT systems to do so. So we collect demographic information, we collect allergies and adverse event information, medical history, and medication history. We collect a number of documents. About 70% of our medical records in any of these electronic medical record systems are document-based. And so we collect many, many of those documents. Encounter histories, problem lists, diagnostic and procedural information, vital signs and immunization history, radiology, laboratory, and even some social determinants of health we're beginning to collect now. We have a number of ways in which we push this information out to clinicians around the state. The most used and the central service that we provide is an electronic clinical portal, which takes all of the information we have on patients and makes it available in a view. This is actually a view of our system as a test patient. So this is not HIPAA data that I'm showing you, but it's in a medical record view that's accessible from electronic health records by clinicians for a patient to show all of the information on that patient from all the facilities that we collect data on. And we try to make it as easy as possible for clinicians to navigate this information. You start in with a splash screen that includes their demographics and allergy, active problems, which are the active diagnoses. And then we have encounter information as well on that splash screen. And then on the left-hand side, we have a whole number of folders that are identified to find additional information and help the clinician find information they need on their patient to make decisions. This past year, we rolled out another service, and this service, we call it HIN Context. It's an application that actually works very closely with electronic medical record system vendors. It's a certified system that actually puts the health information exchange within the electronic medical record system. It's set up to work with different vendors because they all have different standards that they're working with. But essentially what this does is it allows a clinician to access Health InfoNet data without having to take the step to click on the link to Health InfoNet, enter their password, and enter the clinical portal that you saw just previously. This includes data right in the screen inside of their medical record system that they're working with day in and day out. The purpose of us moving forward with this is because we know that clinicians are busy and they need information within their workflows, as many of you know. And so we worked with another health information exchange, the one in Maryland called CRISP, to deploy this in Maine, and we're continuing to deploy it throughout to make it easier to get access to information within clinical workflows. This is just a quote from St. Joseph's Gastroenterology Group. Health InfoNet is used quite a bit. I'm always impressed by how important Health InfoNet is to many clinical workflows around the state, for everything from care coordination to procedural preparation. It's amazing how much Health InfoNet has provided necessary information for many clinicians throughout the state. And for us as a health information exchange, we've begun to help other HIEs nationally to replicate some of the successes that we've had here in Maine. Some other services that we provide real-time notification services, as I mentioned earlier, where clinicians can identify themselves with patients. These services continue to expand. This is one of the areas that we've grown quite a bit on, and you can see even in this screen, this is an actual screenshot. We created a COVID-19 laboratory result notification. As soon as COVID-19 became a threat to our state, we see this data in real time. The test results as they're coming in from the health systems, and we were able to create a number of COVID-19 functions, including notifications. Health InfoNet also, as I mentioned earlier, focuses on population and public health. We have an excellent relationship with the state Medicaid program, MaineCare. And we are able to take MaineCare claims data and also use the information that we get from electronic health records and these other systems within the state to help MaineCare understand what's happening with their patients across the state for specific purposes. What you see here is a view of one of our analytic systems that's showing emergency room usage in the state of Maine last year. And you can even see that big dip. That big dip was March of last year when COVID-19 appeared. So these systems were able to aggregate information and make it available very quickly to help even our Medicaid program to understand what's happening with the healthcare systems and really start to look at organizational performance, population risk, and even the risk for future healthcare activities using our predictive analytics systems as well and tools as well. In some cases, in some organizations, they have their own tools for analytics. And again, our role is to be the trusted organization that can move information and make it useful for the purposes as I've outlined. And in some cases, some of these organizations are looking for us to push data to them when one of their patients is having events of care or has information that's relevant to, for example, their care management systems. And so what we also do is we also do push data down to organizations to help them incorporate our data into their tools so that their clinicians and their clinical staff can make better decisions using their own tools and keeping people in workflow. As I mentioned, we have a very large role with public health. Health InfoNet automates syndromic surveillance for the organizations that work with us. We do the mandated electronic laboratory reporting for Maine CDC. We also do immunization reporting for the state's immunization registry impact. This is just a quote from Dr. Stephen Sears, and a board member, as well as a former official in the state government, a former official at the VA, and now a consultant with Maine CDC. As I mentioned, consent is very important. People have a choice to participate in Health InfoNet. Health InfoNet's consent is in state law. And Health InfoNet is responsible for managing those consent options. The consent relationship is between Health InfoNet and the individual. And participating organizations are also required by law to educate patients on their consent options at their first point of contact within those organizations. As I mentioned earlier, we have a general medical opt-out, which means that patients can opt out of Health InfoNet at any time. And upon opt-out, we confirm that opt-out and we remove their data from the Health Information Exchange. A patient, and we have this happen very often, can also opt back in. But when they opt back in, and this is part of the education process, we don't go back in time. We just move forward in time, because data, what we found, certainly in the health data world, is going back in time and asking EHR systems and all these other systems to replay information from previously is fraught with potential error. And again, our goal is to have the highest quality medical information available, but that does present a risk, certainly for patients who have opted out. When they opt back in, their medical history is not there. We also offer, we also manage an opt-in for sensitive information. As I mentioned, mental health information is the key focus. Not yet substance use disorder. I'll be talking about that in a moment, what our focus is on substance use disorder moving forward. And that opt-in works very much like our opt-out, except for with the opt-in, that the patient's information is not available in the Health Information Exchange unless a clinician declares an emergency. We do have an emergency consent process that allows a clinician to declare emergency and get access to that mental health information, but otherwise the patient must consent for that access. That emergency consent is part of the consent decree issues that you may have already heard about in other conversations. We also spend a lot of time educating because HIE participating organizations have a requirement to provide the consent forms and the consent information to patients at the point of care. We spend a lot of time educating organizations. We go through many trainings per year with organizations, and prior to going live with Health InfoNet for any new organization, they must be active with patient education at the point of care, and we confirm that internally. As far as updates, obviously, as I mentioned earlier, COVID-19 has been significant and had a significant impact. And obviously, because Health InfoNet has so much data flowing to us, we have had a role here. As COVID-19 appeared in the state of Maine in March of last year, we began working to connect to the state's Health and Environmental Testing Laboratory. This is the COVID-19 confirmation laboratory. So that we can make sure that we had the most up-to-date COVID-19 results within the Health Information Exchange for clinicians as they're seeing their patients. We also expanded and worked with the healthcare systems to expand the data types that we're collecting. So for example, race and ethnicity. We've heard even today about the disparities related to COVID-19. We began and expanded our race and ethnicity collection so we can associate race and ethnicity within our systems and support Maine CDC as they're trying to understand what those disparities are. We also expanded our data collection to include ICU bed identification and ventilator use so that we can help Maine CDC understand what's happening in real time. As well as our own provider community understand what's happening in real time in regard to the severe cases of COVID-19. We're currently working with the Maine CDC and the state's immunization registry to receive all of their vaccination data for COVID-19. As I mentioned, we have a relationship with the state's immunization registry, but traditionally in the past, it has been one way. We have supported healthcare providers in submitting data to the registry, but we did not receive data back. As a result of COVID-19 and the recognition that healthcare providers need to have the most current vaccination history for patients as close to workflow as possible, the Maine CDC, Department of Health and Human Services, has agreed to move forward with sending data to Health InfoNet for COVID-19 vaccination. So our technical teams are working as we speak to make that connection happen. Finally, we've also, as I mentioned earlier briefly, we've created COVID-19 laboratory result subscription notification for clinicians so that they can tell us that they'd like to receive a notification on single patients or a panel of patients, and we can send out real-time notifications when COVID-19 results are available so that clinicians can keep ready track of changes for COVID-19 status for patients statewide. We've also developed a series of analytics tools that are in use by Maine CDC, state epidemiologists, as well as our clinical community, where we're taking that COVID-19 data that I just explained to you that we're collecting, and we're mapping it out and in different ways. You can see some heat maps here related to COVID-19 testing in the state. We're also looking at healthcare utilization tied to COVID-19 to understand the morbidity of COVID-19 related to different demographic categories, age, gender, and other categories, race, ethnicity, et cetera. These dashboards we built in a software reporting system called Tableau, which is a very easy to use and well used data reporting system statewide. And we've made this available to any clinical site as well as to Maine CDC and HHS personnel that have requested access. We continuously update this system to support the pandemic. So for us, our 2021 priorities this year is to continue that analytics work. It's become very important, and as we learn more about this pandemic and the healthcare needs of the community, it's become even more important to help identify risks, identify areas where need happens, and our partnership with Maine CDC and our health systems to do so has just expanded as a result. We're also making some necessary upgrades to our infrastructure to support these things. As you can imagine, security is a major issue. And so we're continuously updating our security posture. We received certification last year under some of the highest federal security standards, and we continue to invest in that security infrastructure and our computing infrastructure. Cloud technologies are being used now to support even further advances so that we can grow and be expansive, but also be as secure as possible. I mentioned earlier social determinants of health. This is a buzzword, but that encompasses a lot of different data elements, but it's really important for us. Our organization has been working with many different organizations statewide. We're engaged with Maine DHHS and Medicaid right now on a long-term care initiative to connect all of the skilled nursing facilities around the state through 2021, but also recognize that there are other organizations that are supporting persons that are in the long-term care and home care needs and even aging in place. And what we want to do is make sure that we can give access appropriately and consented access to our data for folks that need it. Think about the area agencies on aging and other organizations. So we're working through opportunities like that. We're waiting to hear back from Robert Wood Johnson Foundation. We submitted a grant to them to further that work I just described to you. And then finally, one of the big changes coming out of last year is one of a legal nature. The federal government has addressed something that's been a real challenge for our community, I think for all communities nationwide, which is the separation of substance use treatment from mental health treatment, from general medical treatment in state law and privacy law and federal law. The federal government has provided new guidance and on what's on this federal law called 42 CFR Part 2, which is the federal law that governs substance use treatment privacy. And what they've done is they've aligned it to the laws that we have in the state of Maine that represent mental health. What that means for us is that today, as of right now, we don't accept substance use treatment data in the health information exchange, even if a patient wanted it to be. But we do accept mental health, as I mentioned, with an affirmative consent by the patient to share that. Over this year, we're going to be working with our healthcare systems to tease apart this new federal law and build out a means by which patients, if they want to, and if they choose to consent, can also share their substance use treatment information with Health InfoNet, but ultimately for the purpose of sharing it with other providers within their care network. So those are things that we're focused on this year. There's a lot of detail underneath that, and I want to leave some time for questions from you all. But I really appreciate the opportunity to see you all today. Unfortunately, not in person, but I appreciate all the work that you're doing for us, and look forward to answering your questions.
Thank you, Sean. If you could, unshare your screen, then we'll take a first question from Representative Zager.
Thank you, Mr. Chair. That was a really terrific presentation and very promising in terms of achieving what I see as one of the holy grails of medical informatics. all this interoperability. I was interested in, my question is surrounding Health InfoNet context or hidden context application. I think you said that some EMRs have already integrated that into their systems, but apparently not others. Is this just a matter of time, or are there barriers that exist from your perspective?
I think they're right now we have integrated, we've integrated across the main health system, and now we're working with Covenant is our next one down the line, and then we're going to be hitting up other healthcare systems as we go. There's two factors to get it to making this readily available. One is the EHR system in use by the organization itself. Different EHRs use different standards. What we've done is that we've codified around what's called the Smart on Fire standard, which is a standard that's being promulgated by the federal government and the Office of the National Coordinator for Health IT, as well as CMS. Some EHR systems have codified to that. Others are catching up, and that's part of the federal Meaningful Use program and some of these other federal incentives to drive interoperability. But as a result of that, some of the EHRs are more ready than others. In addition, some EHRs have their own interoperability functions. And so what we've done is, what we've said is we'll provide that application for those organizations and those EHRs that want to support it, but we'll also make available our data to push directly to the EHR if they want to accept that data in that direction. So at another healthcare system in our state, we're working through the strategy of us pushing data directly to their EHR for rendering within their EHR itself, separate from our application, because that's their preferred EHR path. So what we try to do, and it's an interesting place, is to have one solution that supports many different needs. And so our application I'm sure will be used and further adopted across the state, but I do anticipate that there will be other organizations that will either choose for us to send data directly or have a workflow whereby our clinical portal itself that I showed you at the beginning of the presentation is a preferred route, just because that's a workflow that their clinicians are used to using.
I have one quick follow-up, if the chair would indulge me on that.
Please.
You said that I think 1.7 million people have Maine data, data on care delivered in Maine. How many people across the country have information in Health InfoNet?
So the 1.7 million people are the number of unique lives within Health InfoNet today. And of that, Maine has approximately 1.3 million people that actually reside here full time. So the remainder, the difference are the out of state lives. And so right now, and our work, as I mentioned, we do work with other states, but that work with other states, the systems don't talk to one another. They're logically separated. So when we do work in Vermont, it's in separate servers, separate systems, and the data is not intermingled.
And so recognizing that there are those silos, how many people is that approximately?
Across for the services that Health InfoNet provides to the other states as well? Is that the question, sir?
Yes.
I believe it's at this point, I don't know the exact, why don't I get back to you on that, Representative? Because I don't want to give you a number that's not correct.
Sure, that's fine. Thank you so much.
Yep.
Are there any other questions for Mr. Alfred? As somebody who was practicing before HIN, it's been amazing to watch this tool evolve, and there's just greater and greater possibilities all the time. So thank you for your efforts all over that time too.
Oh, well, thank you, Senator Claxton. We appreciate it and appreciate all the inputs that you all have provided, and certainly the efforts. We wouldn't be here if it wasn't for the healthcare community who has really supported us and continues to support us.
Okay, well, thank you very much. And you owe Representative Zager some information.
Yep.
And you can either get it to one of our analysts or to him directly, and he'll share it with us.
Okay. Will do.
Thank you, Sean, for being here.
Have a nice day.
Next, we're going to hear from the Quality Improvement Council, and there is Ms. Buffard. Welcome.
That's me. Sorry, my cat jumped up at the same time.
Yesterday we had a cat, a parakeet, and a cuckoo clock. So one cat's a small thing today.
Well, I have several cats. I have all that stuff in my house. So it's amazing that now we're working from home, so you get to see a lot of different things. So I'm Diane Buffard. I am the chair of the Quality Improvement Council. So I wear many different hats. I also work for Gear Parent Network, where I'm a certified family peer specialist, and I work with families who have kids with behavioral health issues. And the most important thing is I'm a parent of two children with behavioral health issues. So the Quality Improvement Council it's in statute, and it's because we get SAMHSA block grant money for mental health and substance use. And so because we get that, it says that we have to have an advisory council here in the state of Maine, and that's what the Quality Improvement Committee is. And it's made up with, there's some mandated slots on it, somebody from Office of Behavioral Health, somebody from Office of Child and Family Services, somebody from Department of Education, from Department of Corrections, and the Department of Vocational Rehabilitation. And then the most important thing is that we have to be made up of at least 50% of persons with lived experience and parents of kids with serious emotional disturbance and family members and community members. So we're more than half of people with lived experience or community members. So we want you to know that we're here. You guys can reach out to us for feedback if you have any questions, because we work with a lot of different families throughout and consumers throughout the state of Maine. So,
well,
I don't know. Is there any questions for me?
Does anybody have any questions for Ms. Buffard? Sounds like you wear lots of hats.
I do. Keeps me really busy.
Well, good. Well, thank you for letting us know a little bit about the Quality Improvement Council. Have you an annual report or anything that you create?
We don't, right now we don't do an annual report, but we do work on the block grant. We have to do certain things to help with the block grant submission every 2 years, which is coming up in September. The block grant application will be due again. But we have, like last year, we did public forums to get feedback on how people were doing. We're going to be reaching out to families and consumers to see how they're doing through this pandemic, because obviously a lot of things are going on with people's mental health during this pandemic.
Mm-hmm. If you put that into a summary form, then maybe that's something we can discuss next year.
Okay, we'll do that for you.
I have a question from Representative Stover.
Yes.
Hi, Diane. Nice to see you.
It's nice to see you.
I'm wondering, does the Quality Improvement Council either review the planned expenditures of the block grant or either before they're allocated, or do you have oversight of the spending plan, the allocation plan for the block grant?
We do. So most of the adult block grant money, because the mental health block grant money is split down the middle. 50% goes to children's services, 50% goes to adult services. And some of them, the adult services are paid, peer services are paid for, and some of it is for uninsured people to get mental health services. So some of the clubhouses, some of the peer centers get some money, a lot of different agencies. And for children, the family peer specialists get a portion of that money. There's a youth peer support program here in the state of Maine that gets some of the money. And then the rest of the money goes for first episode psychosis that we know is so important also. So does that answer your question? We do. We look at it. We see how it. So a couple of years ago, we went with the people from Office of Behavioral Health and OCFS, and went out there, did a check on all those contracts. So we did that a couple of years ago. We went out and we added some questions about barriers and all that to see what the barriers were. Obviously, the wait list is a big barrier right now. Transportation for people. So yeah, we know this barrier. So we were identifying barriers to services.
I'm glad you're still doing it. You're a great advocate.
I try. I've been the chair for about, I think I'm going on my 7th year. So, and I really think the Quality Improvement Committee has a lot, and we work really well with OCFS and OBH. So we have some really, really good members there.
That's great. Thank you.
I don't see any other questions, Ms. Buffard. So thank you for being here and thank you for your years of service and ongoing work.
And thank you guys for having me. And I hope everybody has a wonderful afternoon.
Thank you very much. Next, we're going to be joined by Mr. Campbell, Bruce Campbell. And when he unmutes and becomes visible, we're going to hear about the Substance Use Disorder Services Commission. There you are. You're still muted, sir.
I'll get it together here pretty soon. Apologize. And jacket and tie on Zoom is the first too. So yeah. Thank you for having me, Chair Meyer and Chair Claxton. My name is Bruce Campbell. I am the acting chair for the Maine Substance Use Disorders Services Commission. And I do have a presentation that I would like to share. And I would like to, it was mentioned previously that this particular presentation is reference to an annual support that has been submitted to your commission. If you don't mind, I'll just kind of go through this and entertain any questions you may have afterwards. So let me go to slideshow here. Maybe I won't. I'll just stick with where I'm at. So 2 years ago, Public Law 432, an act to amend laws governing Substance Use Disorders Services Commission, which was actually brought forward by Ann Perry on your commission, reorganized the commission into the areas of prevention, intervention, treatment, and recovery. We regard those as the 4 pillars of our work. But our charge from that statute is to act as an advocate and a resource for the state on substance use disorders. And again, as I mentioned, prevention, intervention, treatment, and recovery. We review and evaluate on a continuing basis policies and programs that relate to us. We also make recommendations to the department, the governor, and the legislature through an annual report that we're supposed to file on an annual basis to Health and Human Services and Appropriations. I will tell you that there was not a report done last year. And so this is actually a 2-year report. But that report must include developments and needs related to our charge. So the commission meets on the second Wednesday of every month from 9 to noon. It's open to the public. I would like to point out that since I've filed the report, Senator Rosen and Senator Maximum have been appointed to the commission as well. But I'd also like to point out that the nomination and approval process has not been completed yet. So this is the roster that's kind of been the operational roster going forward, but the nomination and approval process has not been quite completed by the governor yet. And we usually have anywhere between a half a dozen and a dozen people from the public attend the meetings as well. So like everything else, huge impact from the coronavirus pandemic. And it took a really hard toll because these individuals and families were already vulnerable to the issues related with substance use disorders, particularly the issues of isolation, chronic stress, lifestyle disruption. None of these are unfamiliar to any of us, but they've shown a rise in alcohol use and an upward trajectory in opioid overdose deaths. Alcohol use has increased to deal with the chronic stress associated with the pandemic. It's going to have a debris field of its own down the road. And sadly, our drug deaths have been projected to exceed over 500 this year. That's the highest number of deaths ever recorded. The year before, there was a decrease, but now we've increased and exceeded that. We can only attribute that, given the number of interventions and things that have taken place, to COVID-19. But like everything else, there have been some additions to how we do business that have been very helpful and won't be going away. That's primarily telehealth, the use of virtual platforms, and just an increase in public health consciousness and safety. So perhaps the biggest change, well, not perhaps, I will tell you the biggest change that's occurred over the past couple of years was when Governor Mills issued a series of executive orders that established the governor's Prevention and Recovery Cabinet, appointed Gordon Smith as the Director of Opioid Response, and that led to the development of Maine's Opioid Response Strategic Plan. This is the first time that I recall there being an overarching cross-sector systemic response to substance use disorders. The plan had 5 focus areas and 9 priorities, 20 strategies. But for the very first time, there's a significant appreciation for substance use recovery as a process to be supported at all levels. And perhaps my favorite picture is a picture of Sharon Field, who's the volunteer coordinator at the Bangor Area Recovery Network. And she's sitting directly next to Governor Mills and Gordon Smith at the first convening of their Prevention and Recovery Cabinet. But in addition to that, there have been annual opioid summits. And the first one was in 2019. And it really was a gathering of the tribes, if you ask me. You know, over 1,000 people attended at the Bangor Civic, or at the Augusta Civic Center. And it really raised consciousness about what it is we're trying to do and move forward. The next year, it was a virtual conference, and there's another conference, there's summit scheduled for next year. But also, not only is it good to raise consciousness out in the community, it's a way for the departments and the system to report back what's been done and to almost be held accountable to what they have done over the past year. Through the entire last year, we we knew that the opioid epidemic never went away. COVID-19 simply bumped it off the front page. We cannot forget alcohol and other drugs. We cannot address opioids without addressing alcohol and other drugs. Marijuana is now legal, which is another whole nother conversation, but there's also been an increase in cocaine and methamphetamine use and those associated drug deaths. So one of the things that's been done over the past couple of years, again, has been the maximizing of federal and state resources. Number one in that, hands down, implementing Medicaid expansion. It not only expanded access to treatment, it also expanded treatment capacity itself. Utilizing federal grants that are out there. A couple of years ago, they were talking about there was $2 million left on the table, unutilized. That's not the case anymore. they've done a lot about expanding cross-sector integration and working on developing that kind of data system capacity and a treatment locator system. So prevention is the one area of substance use disorders that's really the broadest. It takes the broadest stroke, and it deals with young people, it deals with teenagers, it deals with adults. You've seen the vaping campaigns on TV. They also developed a marijuana prevention toolkit for communities when they were looking at what's legalization of marijuana going to look like. They hired a coordinator to help support families with infants from the effect of substance use. And all of this was done through coordination with the Center for Disease, CDC. The funding for substance use prevention was actually moved to CDC during the last administration. And so they work lockstep with OBH on their prevention programs. They're working with the commission on developing a 3-year statewide prevention plan. And they're also holding a virtual alcohol conference in April, and registrations for that are now open through AdCare. In the intervention harm reduction realm, there's been an expansion of the safe syringe distribution, syringe exchange programs in a lot of the areas where there was high use but no access. There's been incredible distribution of Narcan. And while that's resulted in what we call 1,600 formal reversals by emergency personnel, we know that the people that have received the Narcan have been using it, and there are thousands and thousands of additional Narcan reversals that there's no way we're ever going to be able to quantify. We just hear the stories about it all the time. But most recently, the department has received a federal grant to implement what's called the Options Program. It's overdose prevention through intensive outreach, naloxone, and safety. And this is where they will pair a behavioral health specialist with emergency response in every single county in the state of Maine. It also has increased Narcan distribution systems, safety information around the Good Samaritan law, but also resource information. One of the things people always say is, where can I go for help? So if you go to their new website, knowyouroptions.me, you'll find a treatment locator on there that I think is really, it's the best thing I've seen. And that website is less than a month old. It's very clean, it's very user-friendly, very intuitive, and I think you'd be impressed if you took a browse through it. In treatment, again, expanding access to medication-assisted treatment, rapid access induction of MAT in the emergency departments is now happening in 20 of the 33 EDs statewide. There's low barrier MAT for targeting homeless people, where they will go to the shelters, pick people up, go bring them back for dosing, and then send them to a group and then take them back to the shelter. And also expanding MAT access in treatments in jails and prisons. And Representative Perry also has a pilot program to coordinate treatment access in rural areas that we're going to be looking forward to hearing more about. And then lastly, they have developed an entire system for recovery support that was not there 5 years ago, was barely there a couple of years ago. And so this has involved the coordination of a network of recovery community centers through what they call the Hub, which is administered through the Portland Recovery Community Center. Other community recovery centers are just kind of emerging organically. There's been an expansion in recovery coaching and a deployment of recovery coaches to emergency departments, increase in recovery residences, and increase in recovery employment support. one of the things that can support recovery almost more than anything else is a good job. And a good job will lead to housing, will lead to everything else. And so finally, there's some recommendations that we're just helping to support as well. That is joining with the departments in the calls for action to reduce stigma and discrimination. Still a huge, huge issue. You would think that we've gone further than we have, but we haven't. Again, maximizing resources, trying to mitigate what might happen around the resource restriction due to COVID-19. Removing any barriers to naloxone distribution. Right now, if an EMT provides an emergency Narcan reversal, they cannot distribute another Narcan kit to that individual as they're being discharged. There are all sorts of other areas where Narcan can be distributed, but the regulations for EMTs to be able to do that prohibit them, and so there'll be legislation coming forward about that. Unmet residential treatment needs, there's only 2 detox centers in the entire state of Maine, and now the residential treatment centers can be supported to expand by being able to move above the 16-bed limitation that they had prior, by Maine having their 115 waiver approved. Again, reducing biased hiring practices for persons in recovery. Things will be coming forward about that. And there's also some efforts to expand and establish recovery community centers in every county in the state. Right now, there are 7 counties that have no recovery centers at all. So given that, I would be glad to try to answer any questions, and I certainly appreciate your time.
Thank you for your time and your testimony, Mr. Campbell. Are there questions for Mr. Campbell? Yes, Representative Zager.
Thank you, Mr. Chair. Thank you, Mr. Campbell. I appreciated that presentation. What is your assessment of the availability of counseling services, which is, of course, an important component of Suboxone or buprenorphine treatment?
It's been extraordinarily impacted by COVID-19. Prior to COVID-19, outpatient services and intensive outpatient services could pretty much expand to meet the demand. One of the biggest barriers right now is they're having a hard time developing the counselor workforce to manage the increased demand. And for the first time, a lot of these outpatient programs are having wait lists, and that was never the case prior to that. And again, I think that's a lot has to do with, you know, the impact that COVID-19 has had on people. It's had on all of us. I don't know if I answered that well.
Yes, thank you.
Okay, Representative Craven.
Thank you, Mr. Chair. Thank you for the presentation. How consistent is the program to pick up folks who are homeless so that they can get their MAP treatment? You know, is that like on a daily basis, or how is that working?
Well, I can only speak to the one program that I know about specifically in Bangor, and that's very consistent. It's a program operated by Penobscot Community Health Care, and they also run a shelter. So they have access to folks, and they actually have a bus that goes and picks them up at the shelter each day, takes them over for dosing at the medical clinic, and then they go and participate in a therapy group before they're then transported back to the shelter. And that happens 5 out of 7 days, I believe.
Does that answer your question, Representative Craven?
Yes, thank you. I just wonder, if they're getting Suboxone, for example, what happens with 1 or 2 days where they don't get the MAT? Do they have recurrence or,
No, they're able to continue their medication. It's just that I think the transport, I'm not exactly sure how it's done. I apologize. But I know that there's not a break in treatment over the weekend. There is a break in participating in the groups.
Thank you very much, Ben. That's good.
Representative Stover.
Yes, thank you. Thank you, Bruce. I want to go back to the slide where you mentioned being able to quantify Narcan use. And I'm wondering if either within your group or separately, if you've had any discussions about what's some methodology we could use to capture some of that data. For instance, even if it's through just the amount of use in first responders, whether that's through EMTs and ambulance services or police and sheriffs, if any of that, especially any of the Narcan that's supplied to first responders, if we could trace any of that. My point is, if we can understand better who's using the Narcan and where it is, and I know I'm not going to assume, and if there's follow-up linkages made from that point, from that contact, it would just be another way that, I know it sounds like a rather daunting task, but it would be another way to get to have an access point with people who are at very high risk for dying or have already died and been revived. So it's just about this, when you said quantifying Narcan use, it's just sort of stuck in my head. I do addiction outreach in Boothbay Harbor, so I'm familiar down here of what we deal with. And, I do outreach, so I'm able to follow up directly because I work with the police department. But I think in the big picture, we could quantify that use and find a way to link that to outreach and follow up. I think it could really help. Thank you.
So I can speak to perhaps two different kind of approaches to your question. There is a system that's been put into place around tier 1, tier 2 distribution points. And so like Bangor Public Health is one of the areas. I know Portland Public Health is another area where they can make distribution to other entities that have been trained to distribute. And so there is a training that's involved. There is a form that's involved. But what's not being captured really well is if someone comes back for additional Narcan. First off, once it goes out the door, we don't know where it goes. But if they come back for additional Narcan, we can ask the question, do you know if it has been used or were there any reversals? Again, that's a very soft and fuzzy question because they may have given it to someone and who knows that they may have used it. It's very, very difficult. What we do know is it's not a bad thing to have out there in the community. I think a more appropriate tracking mechanism is the opioid overdose tracking map. And so that tracks high risk, high use areas through first responders and law enforcement. And those are the areas where we know about those. And that's much more hard data that way.
Did that answer your question, Representative Stover?
Yes, it does. Thank you.
Sure. So I don't see any other questions, Mr. Campbell. Again, thank you for being here and thank you for your long service.
Thank you so much. I appreciate it. Thank you for the work you do too. Bye-bye.
So next we're going to hear from Rachel Dyer. And I see she is entered, and when she unmutes, there she is. Welcome.
Great. Thank you. Wow, this is great. This is like, we're getting all so seamless with this.
Can you turn up the volume on your machine?
All right, I'll tell you what I'll do. So, how is that?
Better.
Okay, I'm really sorry. I got this new laptop and my new laptop has a terrible microphone in it. So I'll try and raise my voice at it. So good afternoon, Senator Claxton and Representative Meyer and members of the Health and Human Services Committee. My name is Rachel Dyer and I'm with the Maine Developmental Disabilities Council. I appreciate you taking the time to hear from me and hear from my colleagues that you've heard from on other days to talk a little bit about developmental disabilities in the state of Maine. I appreciate the opportunity to talk about our work and really rather than I submitted our annual report to the legislature a couple of weeks ago, and you should have that already. And rather than put that into a PowerPoint, it's nicer to try and see people's faces when you're talking to them. So I thought that I would try this, although if I'd watched everybody else first, I probably would have done a PowerPoint because I would have been uncomfortable at not having done that. So the report contains kind of the nitty gritty about our enabling legislation. It talks about our membership, details of our work plan, and so forth. And this afternoon, instead of trying to say everything that's in there really fast, I'm going to tell you about the council and its priorities and some highlights of our work as it pertains to the Health and Human Services Committee. Since 2021 marks the 25th anniversary of the closing of Pineland, let's start with a little history and with the establishment of the Pineland School for the Feeble-Minded in 1908. I mean, the early 20th century was an era in which, with the backing of the science and medicine of the time, we built large institutions that were intended to educate and habilitate people who would now be described as having intellectual or developmental disabilities. Most of you are a little familiar with that history and know that within just a couple of decades, the actual function of institutions was to segregate and congregate and dehumanize people with disabilities, and sanctioning abuses from such abuses as forced sterilization and committing a lot of other abuses that were less clearly sanctioned. In 1963, Congress passed the first Developmental Disabilities Assistance Act. And this was during the era of the family support movement, as families began to advocate for education and community supports for people with developmental disabilities. I mean, pretty much today, it's hard to imagine a time when the only way to get any kind of help for caring a loved one with developmental disability was institutionalization. But at that time, that was true. You know, schools didn't have to accept children, and you know, there was no such thing as a community support service. In 1970, DD councils, developmental disabilities councils, were established by Congress to strengthen state efforts to coordinate and integrate services for individuals with DD. And it really went along with, as institutions began to close, and they were largely established to help with those closures. For 50 years, Congress has supported councils to conduct advocacy and capacity building and systems change to improve and coordinate government programs, and to make sure that the people who use the services, so the families and the individuals with DD, have a voice in shaping public policy that affects them, and to promote the self-determination and independence and the productivity and integration and inclusion into all aspects of community life. 60% of the council, so a supermajority, are appointed by the governor and are adults living with developmental disabilities and family members. So they provide a feedback loop between government programs and then the people who use the programs. 6 of our members represent state agencies that oversee disability programs, and all of the council's work is directed by its state plan. and all of its members are full members. We don't have ex officio members. So so when the state agencies participate, they really are, they're able to help direct our work as well, and they're expected to. So the reason I'm here today, and the reason that you'll see the council or some representative thereof in front of you throughout the session, and most importantly, like the reason that you'll hear from individuals with DD and their family members who've been supported through council advocacy initiatives, is that by design, the function of DD councils is to ensure that people are part of the development of those laws and policies. Like most organizations, I certainly heard from the last one, our activities this year were significantly altered by the pandemic. As the scientific and medical community learned more about the virus, it became apparent that people with DD are at higher risk, both at an individual level and collectively due to the way services are delivered. So, so with people being at higher risk when they live in congregate settings, even if as an individual, somebody doesn't have a diagnosis that makes them, more personally at risk. It also became evident that individuals and families who are impacted by developmental disabilities, especially people who do not receive residential services, were really challenged to access both information and supports, that we've heard from families who haven't had a Section 28 service, hadn't had Section 28 services since since March. So by the end of April, so now I'm going to tell, I think, a little bit about some of the things we've done, so by the end of April, there were some clear indications that people with DD in Maine were being unduly impacted, and being impacted by the implications of stay-at-home orders and social distancing. Congregate settings were becoming hotspots of transmission, and services that people use, day programs and community supports, were being shut down or being moved to virtual settings. And we've really known for a long time that people with developmental disabilities and are on the wrong side of the digital divide, and that they lack access to the tools that allow for online and virtual connection, for a variety of reasons, the cost of hardware, sometimes the learning curve for how to use devices, and then some of the connectivity issues across the state. So faced with this crisis that was changing our idea of business as usual, we thought, oh gosh. So the council purchased 147 iPads and reached out across the state to solicit applications for people who would benefit, who would be able to access services or be able to access their families, and who had no other way to do it. So we did this in 1 week. We received, and I sent one email to, I think, 37 people. And within a week, we had 450 requests, and they were still coming in. We had 3 times the number of devices we had to give out. It really indicated a clear and pressing need for better access to this kind of technology. And some of the follow-up was not surprising that people were really better able to connect with their friends and their family. They were able to participate in self-advocacy, and they were able to access healthcare and services virtually. So people were really the people using these were pretty successful in doing so. Also, as a result of the pandemic, we conducted some outreach to identify some of the information gaps experienced by people with DD and families, and did some advocacy to ameliorate the gaps. And if you check out the homepage of our website, there's survey analysis on what did individuals and families have to say about the information they were getting, and how useful it was. And we developed some plain language vaccine material around, so for, as the vaccine came out, we thought, gosh, how are people going to understand this and consent to it? So we did some plain language materials about that. Some other things that are underway that largely have not been disrupted. We have a pilot project to address health disparities experienced by people with developmental disabilities. and some stakeholder engagement and provision of technical assistance to help develop an option for self-direction of adult developmental services. We're working on increasing the understanding of supported decision-making as a legitimate process and as a legal strategy that enables individuals to work with a trusted network of supporters to make choices about their lives and to have some legal recognition and work with that in or outside of guardianship. And we're working to address the use of restraint and seclusion in various main programs right now through a pilot project, testing whether increasing training and technical assistance supervision can impact outcomes. And one of our most important long-term commitments is supporting Speaking Up For Us, Maine self-advocacy organization that's run by and for people with DD. It was created in 1993 to help ensure that people are involved in their communities. And we've provided funding and technical assistance for self-advocates to develop leadership and advocacy skills. And hopefully you'll see some of those folks in front of you. Some of you have before, I know. And to help increase the understanding of and participation in policymaking, and then just to increase the participation in self-advocacy. We were really happy this year that SUFU was awarded, they bid for and awarded an RFP to provide to support self-advocacy statewide, and that was, I think it was certainly the first time that it went out for an RFP, and the first time the organization had all their ducks in a row to receive one. And as the 25th anniversary of the closure of Pineland approaches, and there are fewer and fewer people with that lived experience of institutionalization to tell that cautionary story, we're working to document that history. And this is now an online project, an online educational exhibit. 1 year ago, it was not. But the first part that was undertaken this year was collecting the oral histories of people with personal experience at Pineland and what happened afterwards. And you will find, again, those are the podcasts. They're in podcast format on our website. And we are very happy to say this work has been supported in part by the Maine Humanities Council and the Holocaust Center at the University of Maine at Augusta, and some of the members of the Community Service Provider Organization who've really been helpful with generously sharing their time and experiences. And I close this with a mention of the History Project because it's my hope, our hope as a council, that as a state we really learn from and never repeat the mistakes of the past. You know, data tells us, and we know in our hearts, that people with developmental disabilities are safer and happier, and they're more productive when they live with the people of their choosing in the same places and in the same ways as their brothers and sisters and neighbors do. And when they spend their days in ways that are meaningful to themselves and the bulk of their time with people with whom that they're in freely given relationships. You know, really kind of what lives look like, what we want for ourselves most often. You know, our service system is a lot closer than it was 50 years ago. And I hope that that you all in your role as the HHS committee will keep that vision in your sights as you do this work in this really difficult time. Thank you.
Thank you. I know you'll help us. So are there any questions for Ms. Dyer? I don't see any. So thank you for taking time to be here. Thanks for laying some of that out for us.
Thanks for having me.
Enjoy the rest of your afternoon. So on the calendar that I have, that brings it to the end of the formally scheduled part. But I'm looking to Anna and Aaron. Does anybody want to talk about next week?
Sure. Sorry.
Just lob that to you, right?
Yeah. What time do we start on Tuesday, Aaron? I can't remember. So we have fun
10
helping-
a.m. 10
Okay.
a.m. beginning with Elizabeth Reardon from the Attorney General's office and Luke presenting on the Fund for Healthy Maine, which is also the history of the tobacco settlement agreement.
Right.
So that's
So
how we'll start our Tuesday.
Right. So you'll get different invites. I think this is right, Kerry. So you'll get different invites for Tuesday morning and Tuesday afternoon, because Tuesday morning is our committee and Tuesday afternoon is appropriations. So then you have appropriations again on Wednesday morning and Wednesday afternoon. We're going to have some work sessions on Thursday morning, possibly some book reports somewhere in there too, if you have time. And then one more afternoon in the budget on Thursday afternoon. And Kerry will send that out on tomorrow morning.
And we're working with Molly Bogart to try to schedule a time for Dr. Shaw. So we haven't heard back yet, but when we do, we'll let you know how that affects the schedule.
Have you been getting any questions in yet for him?
Just from one member so
Okay.
far.
Okay. So keep those questions coming. It may be easier to get, quicker to get questions answered than to get Dr. Shaw on the calendar. But anything else that you want to bring up before we consider adjourning for the day and the week?
We'll probably send out an email about book reports to see if people are getting ready to do those so that we can start scheduling them, but we don't want to take anybody by surprise.
Okay. Okay. Well, then I guess I would entertain a motion to adjourn.
Motion to adjourn.
Thank you, Representative Lemlin. And a second, I saw hands go up. So all those in favor of adjourning and having a good weekend, put your hand up.